So this is Buteyko training. It's day 2 and it's the 24th of January 2024. We're going to look at sleep, all things sleep disorder breathing. And an easy way to look at the aspect of Buteyko and sleep is the slides at the back of the Buteyko manual. So hopefully you've received a hard copy of the Buteyko manual that it sent you in the post. And if you did register a little bit late, the manual will be on its way to you. So don't worry, you will get it, but it can just take a little bit of time to reach you. I'm going to put up my manual here, and it's just a little bit easier if I work from this. So just bear with me 1 second, sorry. Let people in. Okay, so we're going to start with this. Now, sleep disorders are very, very common. You know, asthma we spoke about yesterday. Normally, in terms of the people who come into my own clinics, about 30% of them come in with asthma or breathing problems. About 30% come in with sleep problems. Sleep problems are very common. And the other thing is, when you have people coming in with asthma, they're also coming in with a sleep problem, even though they don't know it. Because it's so common that when you have a breathing problem, you have a sleep problem. You have to think about a breathing problem is the lungs have an impact. If there's inflammation in the lungs, if there's a reduction of lung volume. So say, for example, you can imagine somebody who is feeling very uncomfortable with their breathing. And as a result, then they typically breathe using the upper chest. But when you breathe using your upper chest, it reduces lung volume. And when you reduce lung volume, the throat is more likely to collapse. So whether you breathe with good recruitment of the diaphragm or whether you're breathing high in the chest, that's going to influence your sleep apnea. We can't differentiate between the upper airways and the lower airways. It's one airway. So if you have inflammation of the lungs, it's going to impact the upper airway and vice versa. So that link is always there. And when you start talking to people coming in, you know, if they do come into you with a stuffy nose and then you talk, well, how is your sleep? You know, if you start kind of showing them there's a connection between their stuffy nose and their poor sleep quality, then they start to get it. There's something in this because maybe nobody has told them that before. You know, they may have their mouths open for the last 20, 30 years, persistently breathing through it. And in a way, this is always a conversation. Like, how can you how can you determine whether somebody is a mouth breather or a nose breather? It's very difficult to quantify. Is it when you have the mouth open for 5% of the time you're breathing through it, or 10%, 20%, 50%, 70%? How do you measure it? So there is a difficulty in diagnosing mouth breathing. You know, and that's a problem because science, of course, wants to be able to diagnose, is this person a mouth breather or not? And I've only came across 2 papers that looked at the incidence of oral breathing in the adult population. And both papers came back with a result of 17%. But then again, you have to ask, how did they determine mouth breathing? You know, like what factors did those 17% of individuals have to meet before they were labeled as a mouth breather? So there are some gray areas with this, and that's the thing about breathing. There are gray areas. So let's look at the manual. So this is the manual that you have. And I'm going to scroll down to the slides. It's just a little bit easier to work from the slides. So basically, when I'm working with my own, if I was doing a face-to-face training, I always write a few slides up on the board. And that's what we're going to look at now. So when we think about, say, we'll start off with insomnia. And insomnia is quite common. It affects about 30% of the population, but 10% have it chronically. And very often, if a person has PTSD or trauma, or if they're quite stressed, or if they have, you know, racing mind, it can impact their sleep quality. And of course, if you have poor sleep quality, you're naturally going to have a racing mind. It impacts your ability to focus, to concentrate. You're irritable. You're not as productive as you should be. You're tired. All of these symptoms will affect your ability to get on with life. and that then will contribute to anxiety. So it's almost that there's a bidirectional link between insomnia and the mind. If the mind is off, the person will have difficulty falling asleep. And if they're waking up feeling tired, of course, that's going to play on the mind. So two main times that insomnia can manifest. One is difficulty falling asleep. You go to bed and you just don't fall asleep quite readily. You're thinking. And I think overthinking is the biggest problem. And because of overthinking, with too many thoughts going on in the mind, that you're just jumping from one scenario to another, you end up just twisting and turning and you don't fall asleep so readily. The body and mind have to feel safe before you fall asleep. If the brain is interpreting that the body is under threat, the brain will not let you fall asleep. If you're worried about something, the brain doesn't know the difference between a real event and an imagined event. So if you have a lot of thought activity going on in the mind, does the brain interpret that the body is under threat, that there's a real threat, even though there's not? And as a result, then, does the brain keep the person awake in an effort not to fall asleep because the brain is interpreting there's a threat? So we need to tell the brain that we are safe. How do you tell the brain you're safe? Slow down and breathe lightly. It's really important, because there's a bottom-up communication. When you do exercise number 2, this is when you are reducing the volume of air that you are breathing. And the objective here is to create air hunger. By doing this, you have to stimulate the vagus nerve. This causes the heart rate to slow down. And as the heart rate slows down, the brain is going to interpret that the body is safe. The second aspect is that there is a structure of cells in the brain that's spying on your breathing. And when you breathe light and slow, the brain itself, which is spying on your breathing, will interpret that the body is safe and you're more likely then to fall asleep. So it's very important to down-regulate. Now, another thing that should be put in here, of course, is the circadian rhythm. So we should be exposing ourselves to daylight in the morning. Not always easy if things are so busy, for about 20 minutes. And we should be reducing our exposure to blue light in the evening time. So we need the brain to connect with the rhythm of the day. In other words, time to wake up first thing in the morning, time to go asleep later that evening, that night. So circadian rhythm is very important. Improving your control pause, because with a higher control pause, your breathing is naturally lighter, slower, lower. And this in turn will dampen the stress response. So people with a low control pause, we would see that there's dysregulation of the autonomic nervous system, or at the very least, the person is in an increased stress response. And people with dysregulation of the autonomic nervous system, people with long COVID, just as an example, I've seen control pauses of 3 and 4 seconds. And you can imagine with long COVID, it can be such a horrific ordeal for people to work their way through, to recover from it. And it is dysregulation of the autonomic nervous system, and breath hold time is very low, at least in my experience of working. Now, I haven't worked with that many people because we have a couple of instructors who do very much focus on long COVID, and they're better positioned to do it than I, because number one is they have the condition, they're going through it themselves, they know the recovery, they know the steps, they know the pitfalls, and it's much better. They have that direct experience of dealing with it themselves. In addition, so basically they understand the exercise, but also they have the personal experience. So we need to tell the brain that we are safe, and then we can fall asleep. And that's important. The bedroom also should be cool. It should be dark. It should be airy. So cool, dark, airy, and it should be silent. So that's important. Now, the other time that insomnia can manifest is that you wake up after 4 or 5 hours of sleep. You wake up at 3 o'clock in the morning. You're lying there. You're not quite awake to get up, but you're not quite tired enough to fall back asleep. It's almost if you're in limbo. And it can be very frustrating because, especially if it happens Monday to Friday and you have to get up for work in those days. If it happens of a Saturday morning, the pressure is off, because even if you wake up tired, it's your day off if you don't work of a Saturday, and it's more likely that you will fall back asleep. The problem is, though, if you wake up Monday to Friday and you're lying there at 3 o'clock in the morning and 4 o'clock, and you know if you don't fall asleep so quickly, you're going to be exhausted getting up, and that's going to play in your mind. So again, we need to tell the brain that we are safe. We need to get back to sleep quickly. It's not easy to focus on breathing at this point. You can try it, and slowing down your breath isn't easy to help you to help you go back to sleep. So instead, what I did was I created, just put together a couple of audios, guided audios, and they are free. You can download them from the training portal, and they're also up on YouTube. They're up on Spotify as well. So if you are working with a client and your client wakes up at 3 o'clock in the morning, or if you wake up at 3 o'clock in the morning, it's a lot easier to hand it over to something else. In other words, it can be a little bit frustrating that you're lying there, your mind is agitated, you're wanting to fall back asleep at 3 o'clock, you can't, you're racing from one thought to the other, you're twisting and turning. Instead, it's much easier. Play a guided audio, hand the problem over to something else, and let the audio guide you through it, and you're more likely to fall asleep. So two things here with insomnia. Both are when there's agitation of the mind. The more difficult time to fall back asleep is when you are after waking up at about 3 o'clock in the morning. And the reason being is because you're after having 4 or 5 hours of sleep. So now you're not totally tired. And then we have to ask, like, why might you wake up at 3 o'clock in the morning? If your breathing is too fast, you wake up at 3 o'clock in the morning. If you're snoring heavily, you wake up at 3 o'clock. If you have sleep apnea, you can wake up at 3 o'clock. And if the bedroom is too hot and too stuffy, you can wake up at 3 o'clock in the morning. If you're highly stressed, something on your mind, you can wake up at 3 o'clock. So there's a number of reasons why you might wake up at 3 o'clock. So we were talking about just a couple of things here we'll add to this slide. So you might have to take just a few notes yourself, but this is recorded anyway. Why might you wake up? Well, if you're too hot in bed, so if the temperature of the room is too high, or if the bedclothes are too hot, making you too warm. If you're too hot, you breathe faster. And if you breathe faster, it will arouse you from sleep. If you've got a low control pause, you are breathing faster. And if you breathe faster, you can be aroused from sleep. If you're snoring too heavily, your snoring can wake you up, especially if you're a light sleeper. If you stop breathing during sleep, you have sleep apnea, that can arouse you from sleep, especially when you have one phenotype called low arousal threshold. What else might occur? The normal one would be noise, say, for example. But also if you have a lot of things on your mind. So if there's a lot of things on your mind. So there's a few reasons that you can wake up at 3 o'clock in the morning. People with asthma. So they have inflammation of the lower airways, especially when their asthma is not controlled. They're more likely to wake up. And they wake up at 3 o'clock in the morning and they've got faster breathing. So is it the asthma? Is it the inflammation that has disrupted their sleep? Or is it the faster breathing because of the airway narrowing that has disrupted their sleep? So the best solution when you wake up at 4 o'clock and 3 o'clock in the morning is you could focus on your breathing. We've had clients do that, but I think it's difficult. So I would say can you hand the problem over to something else? Listen to a guided audio. And you will find that the pressure is more on you from Monday to Friday and less on you at the weekend if you're not working that weekend. And funnily enough, of course, if there's less pressure on you to go back asleep, you'll fall back asleep. But if you have a high pressured situation or a high pressure job and you're woken up at 3 o'clock in the morning, now that's only going to add to mind agitation, and then you don't fall asleep so readily. So that's insomnia. Increasing your control pause, using breathing exercises to down regulate because of the stress component is also very important, because when your control pause is higher, your breathing is lighter, your breathing is slower. When you're breathing in and out through your nose, your sleep is deeper. So practicing the breathing exercises are also very important, and improving your everyday breathing is very important for dealing with insomnia. If you have a low control pause, if you're a mouth breather, So if you are a mouth breather, you will spend more time in light sleep and less time in deep sleep. So mouth breathing, it affects our sleep quality, that we do spend more time in lighter sleep. So now we go on to our next one. I'm going to look at snoring, which is again very common. Two types of snoring. Oh yeah, sorry there. I probably should have told you it's on page 305. That helps. Thank you, Angela. There's two types of snoring. Snoring through the mouth, and it goes like this if you make this sound. So if you make that sound. And now what I would like you to do is, I would like you to close your mouth and try and snore through your mouth with your mouth closed. Can you snore through your mouth with your mouth closed? No. The second form of snoring is nasal snoring. And nose snoring goes like this. So nose snoring is when there's turbulence in the nasal airway and where the nose meets the back of the throat. So mouth snoring, you can't snore through your mouth when your mouth is closed, but you can snore through your nose. So I know some of you there have tried snoring through your mouth, but instead you're snoring through your nose. So we stop mouth snoring once we get the mouth taped. And taping was first used by Buteyko's patients back in the 1950s and 60s. I've been using tape with my own clients since 2002. And I have to say, it's pretty amazing when you get your mouth closed during sleep. Now, there is something to be careful about, and that's people with obesity with moderate to severe sleep apnea. Because if you tape their mouths, you can actually make their sleep apnea worse. So just bear that in mind. So people who are obese, people with moderate to severe obstructive sleep apnea, if they tape across their mouth, and if those individuals need to be able to mouth breathe, and if they are taped and they cannot mouth breathe, well, then that can make their sleep apnea worse. So we have to be careful about that group. So nose snoring, it's very important then to think about what's causing the turbulence inside the nasal airway. It's not just the anatomy of the airway. When you're thinking about airway, you have to think about flow. So if you had a plumber coming to your house and the plumber is bringing a pipe, bringing water from your mains, maybe from your kitchen sink, to a bathroom somewhere else in the house, the plumber is going to choose the diameter of the pipe to be able to cope with the flow that's expected to go through it. So you have to think about the human airway, not just in terms of the diameter of the airway. What about the flow that's going through it? How hard and how fast does a person breathe during sleep? So you can have a compromised nasal airway, but if your breathing is pretty good, you're going to have less turbulence. But if you have a compromised airway and your breathing is poor, now you've got two things that are feeding into snoring. Does that make sense? So do it again. Make the sound now of a snore through your nose, and it goes like this. Okay, so you've done that. Now what I would like you to do is take a soft breath in through your nose and a really relaxed and slow, gentle breath out through your nose. And as you're breathing really slowly, try and snore through your nose. So as you're breathing slowly, try and snore through your nose, and you'll see there's a difference. So it's not just about the anatomy. It's not just the space at the nose and the space where the nose is meeting the throat, but it's also about the flow of breathing. And yesterday, when we spoke about flow of breathing, we spoke about two things. We said that breathing, there's two things to take into consideration. One is the respiratory rate, which is the speed at which you are breathing. How many breaths per minute? And the other is the tidal volume, is the depth of your breathing. So when you take a breath of air into your lungs, how much air are you drawing into your lungs during that one breath? And when you multiply the respiratory rate by tidal volume, this gives you a minute volume. So if we think about breathing, so for example, on the vertical axis, the y-axis, we'll say this is depth or volume of breathing. And on the x-axis, we'll say that this is time. And your breathing is you have your breath in, your breath out, your breath in, your breath out, your breath in, your breath out, your breath in, your breath out. So we can alter this if we practice breathing exercises during the day. So while we are awake, we can help to change this breathing pattern. And if we have a low control pause, we typically breathe faster. We breathe harder. We're more sensitive to the accumulation of carbon dioxide. We're more likely, there's greater drive to breathe. So we can feel, especially if we have a very low control pause, we can feel that we are not getting enough air. So we feel that we're not getting enough air. And if we feel that we're not getting enough air, it's a very natural thing to breathe using the upper chest. So there's difference in terms of snoring when somebody is breathing harder, faster upper chest versus somebody who's breathing nose, light, slow, and low or deep. Deep in terms of good recruitment of the diaphragm. So we want to bring breathing patterns from here to here. Softer breath in, relax, slow, gentle breath out. Soft breath in, relax, slow breath out. And this is unconscious breathing. So by training our breathing, we can reduce the respiratory rate. We can normalize tidal volume. We can bring a regular pattern of breathing. We can have a natural pause after exhalation. Because all of this happens when the control pause increases. And say, for example, this breathing pattern here, number 1, that would be reflective when your control pause is, we'll say 13 seconds. That's what I would expect. You know, okay, the respiratory rate is fairly regular, but there's no natural pause after exhalation. Well, at least there shouldn't be. You see the tidal volume is fairly pronounced in this example. And we'll say that the breathing rate is relatively fast. And this person here in example 2, they have a natural pause after exhalation. They've got a lighter breathing volume. They've got a slow, relaxed exhalation. And this is very important because the speed of your exhalation during rest, because it's a passive breath, the exhalation is passive during rest. So the length of your exhalation should be about 1.5 times the length of your inhalation. There's no difference here between the inhalation and the exhalation because the control pause is too low. So this person, their drive to breathe is quite strong. And the reason that their drive to breathe is quite strong is because they are quite sensitive to the accumulation of carbon dioxide. And when you're sensitive to the accumulation of carbon dioxide, it will result, or it will be reflected in a lower breath hold time. So by practicing the Buteyko method, the objective is to improve your breathing from a biochemical point of view. And your tolerance then to carbon dioxide has increased. And when you have improved tolerance to CO2, your drive to breathe is reduced. And when your drive to breathe is reduced, your breathing is naturally lighter. You have regular breathing patterns. You're not feeling uncomfortable about your breathing. Your breathing rate is coming down towards normal. Your tidal volume is normal. There's a natural pause after exhalation. You're breathing through your nose and you're breathing with good recruitment of the diaphragm. This is going to impact your snoring. So when sleep medicine when doctors look at sleep, you know, sleep medicine look at one thing, it seems, even though it has changed, but very often the emphasis is on the anatomy. And looking at, well, what is the diameter of the airway? And when we think about the airway, of course, we're thinking about, in terms of sleep medicine, you're thinking about more so the upper airways. But as I said, you know, if there's a problem in the lower airways, it will cause a problem in the upper airways. So you have your nose and you have your nasal cavity. You have your hard palate, you have your soft palate, you have your throat, you have your trachea, and then you have your bronchi. And then they subdivide into smaller airways called bronchioles. A good airway is about the size of your thumb. So when I'm talking about a good airway, I'm talking about the throat. The trachea doesn't collapse, but the throat does collapse. So this part here that's shaded is prone to collapse. The soft palate can collapse in against the airway. Your tongue can collapse in against the airway. The epiglottis can collapse in against the airway. and the throat itself can collapse. So this is collapsible. And if this airway is already narrow, if it's not the width of your thumb, if you have a pipe that's very, very small in places, well, then there's increased resistance. So yes, it is correct to look at the anatomy of the airway. It is correct to think about, well, how high is this person's palate? Is it infringing the nasal airway? Mouth breathers, unfortunately, have a high narrow palate, commonly, especially if they have been mouth breathing for a period of time during childhood. If you have nasal obstruction, it's going to cause obstruction to the airway. If a child has enlarged adenoids, where the lymphatic tissue at the back of the nose, where the nose is meeting the throat, it's really the back of the throat, but in terms of the nasopharynx, if that's enlarged, it can cause resistance to breathing. So really, we need air to be able to flow freely to and from the lungs. But if you're trying to bring this air through a tiny pipe, well, that's a problem because there's a lot more work involved. And it's not just that the pipe has got a very small diameter all the way through. No, it could be just at some parts. The maxilla, the top jaw, could be set back. The mandible could be set back. The mouth is open and the tongue could be midway or in a low resting posture, and the tongue could be encroaching the airway. So it is correct. Look at the anatomy, of course. And what can we do to help improve the anatomy? Well, the first thing to do is get your mouth closed and get your tongue into the roof of your mouth. But the second thing we need to do is look at the flow of breathing. So when we think about snoring, well, what is snoring? Snoring is turbulence. So what is causing that turbulence? It's noisy breathing during sleep. A simple explanation. Noisy breathing during sleep. What's causing that? Two factors. One, well, how fast and hard do you breathe? How fast and hard do you breathe? And we can get some indication of this by the person's control pause. If they have a low control pause, they breathe hard and fast. And the second thing is that the turbulence is created by resistance to breathing during sleep due to anatomical issues, narrow airway. Now, we can help open up the airway because the more you breathe through your nose, your nose decongests. Your nose works better when you breathe through it. We can also help to open up the airway by actually having the mouth closed and the tongue resting in the roof of the mouth. So we can influence the airway, but we can also influence flow. And that's where we're going with snoring. Does that make sense in terms of snoring? Yeah. You're comfortable with that? Yeah. See, the thing is, we don't want to have resistance to our breathing during sleep because if there's resistance to our breathing during sleep, the air isn't able to get so quickly from our nose or mouth into our lungs. And if the air isn't able to get, if the ideal or optimal flow of air is not able to get to our lungs, that can result in a drop in our blood oxygen saturation. And for an adult, if that happens and continues for about 10 seconds or so, and blood oxygen saturation drops by 3%, that would be called a hypopnea. Now, this is where your snoring is going into sleep apnea. So snoring can merge into sleep apnea because sleep apnea considers two main things. One is a hypopnea, when there's a reduction in the flow of your breathing that's sufficient to cause your blood oxygen saturation to drop by at least 3% and that it lasts for 10 seconds or more. And the second part in sleep apnea is an apnea. And for an adult, this is when you stop breathing for 10 seconds or more. So a hypopnea is when there's a partial collapse of the airway. Now, earlier on, we were talking about snoring. Well, we were saying that the turbulence that's created is going to be, there's resistance to breathing. So if you have a person who's snoring, and if their snoring is sufficient, that the resistance to their breathing is sufficient to cause their blood oxygen saturation to drop by at least 3%, greater than 3%. And if it lasts for 10 seconds or more, well, now this is called a hypopnea. So a hypopnea is when there's a partial collapse of the airways or there's sufficient resistance in your breathing that you're not able to get enough oxygen into your lungs. That's a hypopnea. but your airways haven't collapsed altogether. So you are still breathing. It's just that you're not breathing enough air. That's a hypopnea. Or you could have upper airway resistance syndrome. And that's also when there's a resistance to your breathing. But in terms of it wouldn't manifest though, it wouldn't meet the criteria of a hypopnea. So upper airway resistance isn't good either. Like if there's resistance to your breathing, it's a problem, because this resistance to your breathing can take you out of deep sleep. And if you're constantly being taken out of deep sleep into lighter sleep, well, then you're still going to wake up feeling pretty tired. So the next slide then, or that we're looking at, is apnea. So now, of course, we've gone on the spectrum. We'll say you have mild snoring to moderate snoring to more severe snoring to sleep apnea. So it's kind of just a continuum. So this is when the resistance to breathing is mild, the resistance to breathing is stronger, more stronger, if that's the right word. And into sleep apnea is when there's a really strong resistance to breathing. So sleep apnea it's looking at two main things, and that one is called an apnea, and an apnea is when you totally stop breathing during sleep. So you stop breathing. And it's an obstructive apnea when you stop breathing during sleep because your airways have collapsed. It's very common. It affects 936 million people on the planet. That's how common it is. Obstructive sleep apnea. It affects about 50% of men, 20%, 23% of women, and especially as we get a bit older, because the muscles in the throat, which are designed to help maintain an open airway, unfortunately, these muscles get lazy. And that's why we need myofunctional therapy. So what I'm looking at here is the breathing component of it. And I'll break it down anyway to make it as simple as possible. But always think of it this way. We ideally want the air to flow freely to and from the lungs. We don't want resistance. We don't want a struggle of trying to bring this air from the nose or through the mouth. Now, if you breathe in through the mouth, already you have a struggle. Because when you mouth breathe during sleep, resistance is automatically 2 times that of the nose. So we said that we don't want resistance. We want the air to flow freely. But if you're breathing through the mouth, your resistance is automatically double. Now, I would estimate on the observation of working with hundreds of people, and I have asked them the questions, how many of you as adults are waking up with a dry mouth in the morning? And if you wake up with a dry mouth in the morning, it indicates that you have mouth breathing during sleep. It's 50% of the groups that I've worked with over the last 22 years, that 50% of the adult population would wake up with a dry mouth in the morning. And waking up with a dry mouth in the morning, it increases, especially when you have a sleep problem. So coming back to this, we said that you have mild snoring, gets worse, it's moderate, gets worse, it's severe, and at some point that the resistance is strong enough, now you're going into sleep apnea territory. And sleep apnea, there's 2 markers. One is an apnea, and this is when you totally stop breathing during sleep because your airways have collapsed and you're stopping breathing for 10 seconds or more. And the second, what we look at, is a hypopnea. And a hypopnea is when there's a reduction in the flow of your breathing. So you're still breathing, but it's just that you're not breathing enough air. And you're not breathing enough air because your airways are not able to, they're not wide enough to be able to take that air to and from the lungs. So a hypopnea is there's a reduction in the flow of your breathing. So you are breathing, but you're just not breathing enough. And because you're not breathing enough, now your blood oxygen saturation is going to drop. And if your blood oxygen saturation drops by 3% or more, and it lasts for 10 seconds, well, that's an apnea. So when the number of apneas and hypopneas are added up and divided by the number of hours of sleep, so you do a sleep study, you have the wonderful experience of going into, well, especially in an Irish hospital. So you have a horrible room, and in that room you will have a single hospital bed. So a single bed, hospital bed, and you're lying down, and you've got about wires coming out of your head, your chest, and you've got nasal cannula, and you've got this thing is monitoring your sleep to see what is your quality of sleep. Now, can you imagine? You're doing a sleep study, an overnight sleep study in a horrible room on a horrible bed with a load of wires hanging out of you. And this is supposed to tell you if you have good quality sleep or not. So it's very interesting. Now, what the researchers are looking for is they're going to say you sleep for 6 hours. And during that time, if you have 120 events over those 6 hours, well, then the number of hours that you've slept into the number of events, 6 into 120. So now you have what's called an AHI, which is the apnea hypopnea index is 20 events per hour. So at this point for an adult, you will be moderate sleep apnea, and you're likely to be a candidate for CPAP. So a CPAP machine then is the gold standard of treatment. And this is the best solution that's currently available for sleep apnea. It stands for continuous positive airway pressure. Now, the idea of it came from an Australian doctor called Dr. Colin O'Sullivan, and he got the idea from a vacuum cleaner. So you can imagine a vacuum cleaner, which is sucking air. Well, this is a vacuum cleaner in reverse. It's a device that's pumping air at a sufficient pressure into your nose or mouth, well, down your throat, to help splint open your airways. And this is the gold standard of treatment for sleep. But the only problem is 50% of people cannot tolerate it. So in sleep medicine, you're left with 50% of the population with sleep apnea who should be on a CPAP machine. They can't tolerate the very treatment. And this gets worse with mouth breathers versus nose breathers, because in one study, very understudied in terms of mouth breathing and nose breathing, but in one study, individuals who are nose breathing, 70% of them are compliant and continue to use the CPAP. But in that same study, in the mouth breathing, those who are mouth breathing, their compliance reduced by 30%. Sorry, their compliance reduced to 30%. So only 30% of the mouth breathing group were compliant with CPAP. And then the second most common form of treatment is called mandibular advancement device or mandibular advancement splint. And this is a dental device, and it's designed to help bring your lower jaw forward to cause a stiffening of the throat so that your throat is less likely to collapse during sleep. The issue with the mandibular advancement device is it can put pressure on the temporomandibular joint, and also the mandibular advancement device, it doesn't suit everybody. So now I'm going to go a little bit more in detail into sleep apnea. Are you following me so far? I kind of have to go into a little bit of detail with obstructive sleep apnea. It's not so simple, but breathing isn't simple. But I'll keep it as simple as possible. And I do have an article that was written by 2 ear, nose, and throat doctors, and I'll pull it up. And if you read that article, it was peer-reviewed and it was published in the journal Clinical Medicine. I wanted to look at the application of breathing during wakefulness and how it can improve your breathing during sleep. Because how you breathe during sleep is determined by how you breathe during wakefulness. Now, people who have poor breathing during the day are not going to breathe well during sleep. So you can think straight off that people with asthma, but it's not just people with asthma. So I'll continue anyway on the sleep. So we will be about an hour doing the theory, and then what we'll do is we'll do the practice then for sleep. You probably don't need to go into this level of detail when you're working with your clients, but I do find that you need to go into a decent level of detail, because if you can show your client that you understand their condition, it helps. It helps because they're more likely then to, to have confidence in what you're saying to them. So we'll continue. I'm sorry, I just have to close a window here. It's not quite cold. So traditionally obstructive sleep apnea. So think again, what is obstructive sleep apnea? Well, obstructive sleep apnea is when you have collapse of the airway during sleep. It could be a total collapse, that's an apnea, or you could have a partial collapse, and that's a hypopnea. And as we said, you do a sleep study in this wonderful room, and this is supposed to determine how well do you sleep. But of course, you're in a condition you're in an environment that's totally alien to what you normally use. Now, the other thing is, many people, men, it's common enough to drink alcohol. And alcohol will have a big bearing on obstructive sleep apnea, but I doubt there's too many patients having quite an amount of alcohol and then going into the hospital and doing a sleep study. So the result of the sleep study in a hospital is when the person is sober. And it's not then telling you details of, well, if this person is fond of drinking, what is their sleep apnea when you throw alcohol into the mix? So there's another side to it as well. So just to bear that in mind. And if you have 5 to 15 events per hour, it's mild. And typically a CPAP isn't prescribed for that. But if you're going from 15 to 30 events, you have moderate sleep apnea. That's 15 to 30 events per hour. It's moderate. And if you have 30 events plus, it's severe. So moderate is more when the CPAP, at least in Ireland, is often prescribed. As I said, the problem with it is a poor tolerance, that 50% of people will abandon it, typically within about 3 to 6 months. So we'll continue. So what is obstructive sleep apnea? Well, traditionally, obstructive sleep apnea was seen primarily as an anatomical problem. And a very rough definition of obstructive sleep apnea is that when the negative pressure created during inspiration. So you can imagine that as air is drawn into your lungs, there's a negative pressure created in your throat and in your upper airway. So as that air is being sucked into your lungs, that air, as it's drawn into your lungs, is creating a negative pressure. And this in turn is contributing to collapse of the upper airway. So if the negative pressure, traditionally it's seen that if the negative pressure that's created during inspiration exceeds the dilating ability, I'm not sure if that's the right word, but the dilating, I'll just say ability of the upper airway dilator muscles to keep the airway open. So it was kind of seen as a battle, You have the airway collapsing because of inspiration, air being drawn into the lungs. And countering that, you have a group of muscles in the throat. There's about 20 muscles, I think, in the upper airway. And it's a subset of these muscles. I think there's about 6 of these muscles, which are designed specifically to help keep the airway open during sleep. So the negative pressure created during inspiration exceeds the dilating ability of your upper airway to help maintain an open airway. Okay. Anatomical now is one factor. So in 2013, a researcher called Danny Eckert, he came up with what was called PAM classification. He said there's not just anatomical. So this is old school thinking, but anatomical is still one of them. And anatomical is the most common. So people, especially with obstructive sleep apnea severe, they have a narrow airway. They do have a compromised airway. So there's no question that the anatomical phenotype is very, very important to look at. And this is called peak rate. So to measure your sleep from an anatomical point of view, researchers look at the critical pressure at which the airway collapses. And this basically means how much suction pressure does it take is required to collapse the airway. You don't want your airway collapsing at a low suction pressure. You don't want your airway, like a paper tube and it's just floppy and collapsing. You want your airway to be able to withstand a decent suction pressure. So you need your airway to be stiff and dilated. So a good airway is stiff and dilated, open. So that's peak rate. Now we can influence peak rate from a breathing point of view. The second one is it's called arousal threshold. And an easier way to think of this is whether you are a light sleeper or a deep sleeper. In other words, does it take a minor change in your breathing to cause you to waken up from deep sleep? You don't want to be a light sleeper, because the problem is if you're heavy snoring, your snoring will waken you up. Now, it's not that you may be consciously awake, but your heavy snoring could take you from deep sleep to light sleep. So arousal threshold, this kind of ties in with insomnia. Number 3 is L, and that stands for loop gain. It's an engineering term, and really it's talking about how stable is your breathing during sleep. Now, interestingly, we can measure loop gain by your breath hold time during wakefulness. So the length of your breath hold time during wakefulness reflects your loop gain. If you have a low control pause, if your control pause, say, is less than 15 seconds, well, you can be pretty sure this person has high loop gain. And the interesting thing about high loop gain is that 30% of the sleep apnea population have high loop gain, 30%. And individuals with high loop gain and individuals with arousal threshold, mandibular advancement devices don't work effectively with this group. And I think 30% of the population have low arousal threshold. So you can imagine then you have obstructive sleep apnea, you go to your dentist is fitting you with a mandibular advancement device, but if you have low arousal threshold, if you have insomnia, because see the thing about insomnia, this is where there's a crossover of symptoms. We look at insomnia, we'll briefly look at obstructive sleep apnea, and we look at depression. What are symptoms that are common to all three? Fatigue. If you have insomnia, you can be fatigued. If you have obstructive sleep apnea, you're fatigued. Not always, but you can be. And if you have depression, you can be fatigued, low energy, irritable, difficulty concentrating. So if you have somebody then with obstructive sleep apnea and they're going to their dentist is checking, well, as best you can in terms of symptoms and things like that. But how do you know whether it's insomnia that's feeding into these symptoms, or obstructive sleep apnea that's feeding into these symptoms, or depression? And you, on the other side, tomorrow, like we'll talk about, you could have somebody with depression who goes to their psychotherapist. And they're explaining to their psychotherapist, well, I have fatigue, and I'm irritable, and I have difficulty concentrating. And of course, the psychotherapist is thinking, well, yes, you have this because this is normal when you have depression. But I wonder, is the psychotherapist thinking, well, could these symptoms be actually from obstructive sleep apnea? So the psychotherapist is providing cognitive behavioral therapy, or the psychiatrist might be providing medication, but underlying it, what can be feeding into their symptoms is obstructive sleep apnea. So you see that there's a crossover of symptoms here. And that's why sometimes it's important just to dig a little bit deeper. So people with low arousal threshold, typically they have mild sleep apnea. And the reason being is because they wake up too quickly. They don't have severe events. They're not stopping breathing for 90 seconds because they've awoken so quickly. They've been taken out of their deep sleep. So if you have low arousal threshold, you're a light sleeper. And if you're a light sleeper, you typically have mild sleep apnea. Your blood oxygen saturation typically doesn't go below 82.5%. So if you see then, say, for example, you are a dentist or you are a myofunctional therapist and you are looking at the person's sleep study, what's their AHI? If it's mild and if their blood oxygen saturation doesn't drop all that low, and there is a third factor, I can't think of it, but it's in the presentation. If you score 2 out of 3, it indicates low arousal threshold. That's insomnia. So now you're thinking about, well, what can I do with this person to help them sleep deeper? Straight away, get them nose breathing, get them breathing light, get them breathing slow. Think about sleep hygiene, exposure of the individual to daylight in the morning, reducing exposure of blue light in the evening time, wearing blue light filter glasses, doing physical exercise during the day, but not doing too much physical exercise because that too can be a problem. Making sure that the bedroom is dark and airy. But the elephant in the room when it comes to sleep here is nose breathing. It's so, so important. Loop gain, 30%. So you can imagine again, this person looking for a mandibular advancement device, they have high loop gain. And this means that their breathing is quite unstable during sleep. So high loop gain, you can assess for high loop gain by measuring breath hold time. If the control pause is less than 15 seconds, you know, it is indicating, now this isn't perfect, but it's indicating that you have high loop gain. High loop gain means that the individual is overly sensitive to the accumulation of carbon dioxide. And that's what the control pause is measuring. It's an indirect measurement. So your control pause is an indirect measure of CO2 sensitivity. Because if you have a low control pause, you are overly sensitive to carbon dioxide accumulation. And carbon dioxide is the driver to breathe. And if you're overly sensitive to carbon dioxide accumulation, how will you breathe? Well, your drive to breathe is quite strong. You're going to be breathing faster. You're going to be breathing harder. You're feeling you're not getting enough air. You will have exercise intolerance. You will be breathing harder and faster during sleep. You're in a greater stress response. So you can see that the control pause, even though it's not perfect, you can see how it feeds into sleep, but also exercise intolerance, asthma, because yesterday we said that hyperventilation will make asthma worse. The faster and harder breathing of the person with asthma causes drying and cooling of the airway walls, but also stress, because you have the bottom-up communication. How does your brain interpret, you know, whether you're safe or not based on your breathing? So if you have a high control pause, and we're talking about high control pause, the minimum that we're looking for is greater than 25 seconds. This indicates that you have a good tolerance to carbon dioxide. Now, when it comes to sleep, so you can imagine the person, normally it's the male, although it's common enough in females is 25%, especially post-menopause. So females, as they're getting older, maybe over 50 or 51, 52, 53 years of age, post-menopause, there's a leveling off of progesterone, which is thought to protect the airways and keep the airways open. But post-menopause, there is a leveling off of progesterone. So the female and the male airways, and of course, there's also a distribution of body weight as we get a bit older. So once we hit that wonderful 5-0, we start to put a little bit of weight on the belly. And if we put weight on the belly, what's that going to impact? Well, it impacts the movement of the diaphragm. If the movement of the diaphragm is less than optimal, well, then we are breathing more in our upper chest. If we're breathing more in our upper chest, this in turn is going to reduce lung volume. When we reduce lung volume, well, the throat then is more likely to collapse. So you can see the connection between the lower airways and the upper airways. The lower airway, including your diaphragm, is mechanically linked with your throat. If you have good breathing using the diaphragm, well, then your throat is stiffer and less likely to collapse. But anyway, coming back to loop gain. So we said that we would look at this one here, loop gain. If you've got high loop gain, you're overly sensitive to carbon dioxide accumulation. So you're snoring, heavy snoring, and then all of a sudden there's silence and you've stopped breathing. And as you've stopped breathing, the carbon dioxide is not able to leave the body through the lungs because you've stopped breathing. So carbon dioxide is then going to increase in the lungs because it can't leave the body. And as carbon dioxide increases in the lungs, it's going to increase in the blood leaving the lungs. So carbon dioxide is increasing in the blood. Now, if you're overly sensitive to the accumulation of carbon dioxide, well, now you've stopped breathing, carbon dioxide is increasing in the blood, and you've got high loop gain. If you've got high loop gain, you're overly sensitive to CO2 accumulation. When you resume breathing, you will resume breathing with such exaggerated ventilation. Now your carbon dioxide is going from too high to too low. Now the problem with too low CO2 is that now the brain won't send a signal to breathe. Because carbon dioxide is the driver to breathe. But if the carbon dioxide isn't too low in the blood, well, the brain isn't going to send a signal to breathe. And this can cause a central apnea when the brain doesn't send a signal to breathe. So the brain doesn't send a signal to breathe. Now, when the brain doesn't send a signal to breathe, the output from the brain then to the upper airway dilator muscles is reduced. And this then in turn can feed into another apnea. So we were talking about how stable is your breathing during sleep. People with high loop gain have poor stability. Their breathing is all over the place. They stop breathing, they hyperventilate, they stop breathing, hyperventilating. They're going from one extreme to the other. So when I was giving a conference and one of the lady doctors, I can remember who she is, but I can't remember her name. She was talking about if you go to a hotel and if the hotel has a terrible shower system, you put on the shower and the shower might be absolute freezing cold. And then you turn the shower and then it's boiling hot. In other words, there's nothing in between. So this is a little bit like this. You've stopped breathing altogether because the airways have collapsed, and then you're hyperventilating, and then you've stopped breathing. So that's high loop gain. That affects 30% of the sleep apnea population. How do you improve tolerance to CO2? Well, I can't think of any other way to do it other than improving everyday breathing patterns. And how do you know that you're improving tolerance to CO2? Well, your CP will increase. So this is where breathing re-education can be very, very important in obstructive sleep apnea. And then finally, the fourth phenotype. So we said there's four of them. So P is for pCrit. This is the suction pressure at which the airway collapses. This is anatomical. A is arousal threshold. Are you a light sleeper? Which is not good. You're much better off being a deep sleeper. L is for loop gain. This is how stable is your breathing during sleep. You don't want high loop gain. And M stands for muscle recruitment. So this is getting the muscles in the throat that are designed and their purpose is to keep the airway open, but they get lazy. How do you get these muscles doing their job? It is influenced by breathing because carbon dioxide and nitric oxide play a role, but this is where myofunctional therapy is excellent. So myofunctional therapy is means of a therapy to help to improve the function, the tone of the upper airway dilator muscles, the position of the tongue, correct swallowing, etc. So that's obstructive sleep apnea. So I know it's a little bit complex, and I don't know what degree of complexity do you need to go in, but if you understand it, that yes, it is complex, but breathing can play a role. So if you think about pCrit, how can you influence the anatomy? Well, number one, mouth closed, tongue resting in the roof of the mouth, good use of your diaphragm. But can you imagine the 50% of adults that are breathing through an open mouth during sleep? If you're breathing through an open mouth during sleep, does that affect the recruitment of the diaphragm? Look down at your chest. Look down at your chest. Breathe through your mouth. When you breathe through your mouth, what part of your body is moving? It's going to be your upper chest. So if you're breathing more using the upper chest, does that reduce the recruitment of the diaphragm? Yes, it does. And when you have a reduced recruitment of the diaphragm, it reduces lung volume, and your throat now is more likely to collapse. So the paper that I co-authored with two ear, nose, and throat doctors, it is in your manual, but the only thing is that the one in the manual is the one before peer review. So when it went through peer review, then we had to make some changes to it. Not a whole lot. The essence of it was fine, but there were some we had to make some additions to it. And so this paper here, it's breathing re-education and the phenotypes of sleep apnea. What I wanted to do was, well, number one is, the other thing is, somebody might say to you and they'll say, well, there's no research on the Buteyko method for sleep apnea. They're correct. But there's no research on any breathing exercises, hardly any, for sleep apnea, other than improving heart rate variability. So we'll forget about Buteyko for the moment. What are we looking to achieve? Well, we're looking to establish full-time nasal breathing during wakefulness and sleep. Well, is this important? Yes, it is. We're looking to correct the resting posture of the tongue. We're looking to slow down the respiratory rate so that there's less resistance to breathing. We're using breath hold time to establish the chemosensitivity to carbon dioxide. We're helping to restore diaphragm function with lateral expansion and contraction of the lower ribs. And we want to reduce minute volume towards normal to regulate levels of CO2. So will this influence how we breathe during sleep? And the answer is absolutely yes. Has there been any research in terms of getting a group of people with diagnosed obstructive sleep apnea and improving their breathing, getting them breathing through their nose during the day and during sleep, correcting the resting posture of the tongue, increasing their breath hold time to above 25 seconds, restoring diaphragm function with slow breathing and normal minute volume? There has been no research. So nobody has done that research. So what I wanted to do was I wanted to connect breathing to the phenotypes of sleep apnea. And when you scroll down, so if we breathe through our nose, it can help to improve breathing in sleep from an anatomical point of view. It helps to reduce high loop gain. It improves upper airway recruitment, and you have deeper sleep. So nasal breathing affects all phenotypes of sleep apnea. From a biochemical point of view, we want to reduce the sensitivity to carbon dioxide. This reduces high loop gain. This improves upper airway recruitment, and this can reduce the AHI. So there is a paper looking at what happens when you improve your tolerance of carbon dioxide. It actually does reduce your AHI, your sleep apnea severity. What happens when you improve your breathing from a biomechanical point of view? It increases lung volume, so your throat is stiffer, less likely to collapse. It improves the gas transfer of oxygen and carbon dioxide. So this in turn affects also two phenotypes. And then we bring in slow breathing, resonance frequency breathing, because people with sleep problems, they have impaired or they have suboptimal heart rate variability. They're stressed. They're in an increased sympathetic drive, reduced parasympathetic drive, and we want to help to strengthen the bar reflex and help to bring balance to their autonomic nervous system. We want to improve gas exchange, alveolar ventilation, helps to reduce the chemosensitivity to carbon dioxide, and improves sympathavagal balance. So we can influence sleep apnea, and we referenced it with 170 different papers. So, no, it's 161 different papers. Yeah. So I think there's a good connection here. But yeah, so even though the research, breathing doesn't typically get much research, I have to say, especially nose breathing. And it's unfortunate, and probably because it's difficult to make money, it's difficult to commercialize it. So the incentive isn't then to do the research. You know, it's easier to get research for food products and supplements and things like that because there's something to sell. But if you're just improving breathing patterns, as instructors, we can make a livelihood from it. We can make an income, we can make a living from it, but you don't get the same scale that you would get in a multinational corporation, you know, and that's where the healthcare unfortunately is. Yeah. Okay. Are you comfortable all with that? Yeah. Okay. Let's start off with the exercises. Has anybody compared Buteyko and the CPAP for sleep apnea? Yeah, it's interesting. I suppose over the years, we've seen many people significantly improving their sleep apnea, some of them coming off their CPAP machine altogether. But the CPAP machine is pretty effective. But the problem is 50% of people can't tolerate it. So the best solution that's out there, you have 50% of people have no solution. No solution. They may then use mandibular advancement devices, which again, they can be very, very helpful for some people. But mandibular advancement devices don't help individuals if they have low arousal threshold, which is 30% of people with sleep apnea. And they don't help people with high loop gain, which is also 30% of people with sleep apnea. I'll have to come back to your question, Lucia, so I'll answer that. So let's start off with small breath holds. So we're doing the program for sleep. I always start off with small breath holds because it introduces you to air hunger. So exercise intolerance is that if you do physical exercise, you're overly breathless. So if you're intolerant to exercise, in other words, when you're doing physical exercise, if you're breathing too hard and too fast, if you have disproportionate breathlessness during physical exercise, you're exercise intolerant. So whenever you're ready, take a normal breath in through your nose and out through your nose, and pinch your nose and hold for 5, 4, 3, 2, 1. Let go. Breathe in through your nose and to breathe normal for 10 to 15 seconds. So even people with sleep, because think about if your mind is racing, can you fall asleep quickly? And the answer is probably no. So some of these people can have high stress. People with PTSD, there is a very high instance of sleep apnea and insomnia. So there's a crossover between anxiety of the mind and poor sleep, and of course, poor sleep and how it feeds into anxiety of the mind. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold for 5, 4, 3, 2, 1. Let go. Breathe in through your nose and to breathe normal for 10 to 15 seconds. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold. 5, 4, 3, 2, 1. Let go. Breathe in through your nose and breathe normal for 10 to 15 seconds. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold. 5, 4, 3, 2, 1. Let go. Breathe in through your nose and to breathe normal for 10 to 15 seconds. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold. 5, 4, 3, 2, 1. Let go. Breathe in through your nose and breathe normal for 10 to 15 seconds. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold. 5, 4, 3, 2, 1. Let go. Breathe in through your nose. Okay. So we start off with that. So that's an emergency exercise for the mind, or if your mind is racing, it's the easiest exercise to help bring a quietness to the mind. The next time that your mind is racing, it's not easy to slow down your breathing when your mind is racing. It's not easy to be mindful. It's much easier to hold your breath to help increase blood flow to the brain. And this is the stuff that we will talk about tomorrow. So it's common that if you have a problem with your nose, you also have a problem with sleep. So we need to decongest the nose. The main thing with people with sleep apnea, don't have them hold their breath for too long because they're already stopping breathing during sleep. So we do want them to hold their breath to open up the nose, but not for too long that it would cause them undue stress. So to decongest the nose, take a normal breath in through your nose and out through your nose, and pinch your nose and hold, and gently nod your head up and down for 10 nods. We start off with 10 nods. Do it nice and slowly. You don't have to do it too quickly, just in case you put too much pressure on your neck. And then let go, but breathe in through your nose. Even with 10 nods, you'd start to notice that your nose is opening up a little bit. You know, it is normal during the day that one side of your nose is a little bit congested and the other side is free. And 90 minutes later, or 2 hours later, they switch. This is called the nasal cycle. So you don't ever expect to have both sides of your nose open. But if you do physical exercise with your mouth closed, both sides will tend to open. Or if you do breath holding, both sides will open. And a third way to open up the nose is sex. So there's actually 3 ways. Sex was the most recent one, and they have done a study on that one. So you'll find that on Google. I don't have a reference. So again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold. And now you just gently nod your head up and down, and maybe try it for 12 nods. In other words, we kind of want to push it a little bit, but we don't want to push it too much. So 12 nods up and down. And you should feel relatively comfortable with it. You know, then you're letting go, you're breathing in through the nose, and you're breathing normal. So we'll do this about 5 times. And the thing about the human nose is that the more you breathe through it, the better it works. It's amazing. But many people don't breathe through their nose if their nose is feeling stuffy. Because if you have a stuffy nose and you try to breathe through your nose, it's uncomfortable. If you have air hunger, when you breathe through your nose, you're not going to breathe through your nose. So if your nose is stuffy, you're going to automatically switch to mouth breathing. But all that's going to do is make the congestion worse. Can we try for 15 nods? Take a normal breath in through your nose and out through your nose, and pinch your nose and hold. And just gently nod your head up and down and hold it for 15 nods. So you're just gently nodding your head up and down, holding for 15 nods. Gently nodding up and down, holding for 15 nods. And then to let go, but to breathe in through your nose. So anytime your nose is congested, do this exercise. And doing your physical exercise with your mouth closed is tremendous, especially for people with sleep apnea. Now, the thing about sleep apnea is that it can play up on hormones, and what it can do is it can increase ghrelin and reduce leptin. It stimulates appetite. So a person who is having poor sleep will tend to eat more, because their appetite is stimulated. They often find it difficult to lose weight, and obesity certainly is going to feed into sleep apnea. If you can lose weight with obstructive sleep apnea, you automatically reduce your sleep apnea severity. So if you can lower the body mass index, you automatically will reduce sleep apnea severity. But the problem is the condition stimulates the appetite, the person eats more, they put on weight, and then it's a vicious circle because that makes their sleep apnea worse. Can we do 15 head nods again? Take a normal breath in through your nose and out through your nose, and pinch your nose and hold, and you're gently nodding your head up and down, and you're holding your breath for 15 times. Gently nodding your head up and down, and you're holding your breath for 15 times. Just gently nodding your head up and down, up and down. And then to let go, but to breathe in through your nose. Okay, so we've done that 4 or 5 times. And now what we're going to do is we're going to do the breathe light. Why is breathe light so important? It's when you practice this exercise, which is exercise number 2A or 2B or 2C, it helps to reduce your chemosensitivity to carbon dioxide. In other words, it improves your tolerance of carbon dioxide. Your breathing is lighter, and then there's less resistance to your breathing during sleep. So that's why it's very, very important. It also helps to reduce or lower high loop gain. And you know that you're breathing lighter based on your control pause increasing. Every time that your control pause increases by 5 seconds, you are breathing lighter. So the objective with your client is make sure if their control pause is 10 seconds, let's get them to 15. If their control pause is 15 seconds, let's get them to 20 seconds. You know, so that can be very, very important. The goal needs to be attainable. It needs to be within their reach. If the goal is too far away, it's not going to motivate them. So now what we'll do is some breathe light. So this is exercise number 2A. And this is probably the main exercise for sleep apnea, but also breathing slow and low. We didn't do slow and low yesterday because you'll get most of your results with breathing light. That's why I purposely didn't do it yesterday, but I'm going to do it today anyway. So breathe light, one hand on your chest, one hand just above your navel, And I would like you to imagine that there's a piece of string just gently pulling you up from the top of the back of the head towards the ceiling. Lengthen the distance between your sternum and navel and widen the distance between your ribs. Bring your attention out of your mind and onto your breathing. There's 4 places at which you can feel the airflow coming in and out of the body. One is inside your nostrils. The inside of the nose is very sensitive to airflow. Can you bring your concentration to the area just inside your nose? Can you feel the slightly colder air coming into your nose? And can you feel the slightly warmer air as it's leaving your nose? So do you feel the slightly colder air coming in and the slightly warmer air leaving your nose? The other place at which you feel your breathing is the back of the throat. Or you might notice your chest rising and falling. Or you might notice the area of the diaphragm. So as you bring your attention out of your mind onto your breathing, can you slow down the speed of the air coming into your nose? So you could slow down the speed of the air coming in, or instead of breathing in 100% of the breath, take in about 80%. So the objective is take less air into your body. So instead of 100% of the breath, breathe in about 80%. And then on the breath out, bring a total feeling of relaxation to the body. So on the breath out, bring a total feeling of relaxation to the body and allow the air to leave the body effortlessly. Always use your hands when you're working with your clients, because by using your hands, you can help to change the behavior because your clients are going to be following the movement of your hands. You're taking a very soft and slow, gentle breath in through your nose, and you're allowing a really relaxed and a slow and a gentle breath out. And a very, very soft, slow, gentle breath coming into your nose, and a relaxed and a slow and a gentle breath out. So you're gently softening and slowing down the speed of your breathing to the point that you feel that you're not getting enough air. And you're looking to get an air hunger that's comfortable. So if the air hunger gets too much for you to the point that you have involuntary contractions of the diaphragm, take a rest. So what is a tolerable air hunger? Well, one that you feel comfortable with. And how do you achieve air hunger? You achieve it by breathing less air. How do you breathe less air? Slow down the speed of the air coming into your nose. So as you're feeling the airflow coming into your nose, can you slow it down almost that your breath in is imperceptible? And then allow a really relaxed and a slow and a gentle breath out. So it's a soft breath in and a really relaxed and slow, gentle breath out. And the whole objective is that if I was to look at your breathing, I should see about 30% less movement. So can you hide your breathing from me, but not by holding your breath? Continue to breathe, but just use the word breathe softer. Breathe softer. So all you're doing is softening the speed and the depth of your breathing, that you take less air into your body, and you should feel breathless. You should feel slightly breathless. Feeling slightly breathless is telling you that carbon dioxide is increased in the blood. And it's the increase of carbon dioxide in the blood that's generating the sensation that you would like to breathe in more air. But you're now exposing your body to the increased CO2. And this is helping then to reset your respiratory center, to improve your brain's tolerance of the gas carbon dioxide. So that's the theory behind it. You're reducing your chemosensitivity to carbon dioxide. As you reduce your chemosensitivity to carbon dioxide, your breathing becomes lighter. Your breathing is slower. Your breathing is more comfortable. The drive to breathe is less. Your breath hold time increases. Your sensitivity to carbon dioxide is reducing. Now take a rest. Take a rest. Okay, we don't do maximum pauses with people with sleep apnea. It's contraindicated. Now, I know you're probably saying, well, what about if you have somebody with asthma and undiagnosed sleep apnea? You could, so if you kind of suspect that their sleep is a problem, go easy enough on the breath holds. The maximum pauses are brilliant with people with asthma, but we tend to shy away from them with sleep apnea. Now, Messino did do a paper and he used maximum pauses, but we don't. So one researcher was looking at using breath hold time to measure or to assess high loop gain, to assess loop gain. And we looked at this. So the paper so high loop gain is a phenotype of sleep apnea, which we looked at earlier on. And Messino used breath holding to estimate loop gain. So people with high loop gain have a low breath hold time. And he used two different types of breath holds. He had them do a maximum breath hold and measured it, or he had them hold their breath for 20 seconds. And when they resumed breathing, he measured how hard did they breathe when they resumed breathing after a 20-second breath hold. And the 20-second breath hold was a normal breath out and hold the breath for 20 seconds and then see how hard you breathe. So, yeah, higher loop gain is associated with a shorter maximum breath hold time. And a higher loop gain is associated with a larger ventilatory response. So if you hold your breath for 20 seconds, when you resume breathing with exaggerated ventilation. Okay, can we go again? This time what I would like to, if you have chronic anxiety, go very, very gentle, Zoe. Because what might happen is that the air hunger can tip you into anxiety, which is common. So that's why tomorrow, if any of you have background of panic disorder or anxiety, go easy. You know, we go through, maybe we should be doing the anxiety one first, but you know, I typically do it in this pattern. So tomorrow we're going to go easy. So yeah, if you're feeling at all stressed, if ever your clients get stressed doing the exercises, tell them to go easy. Always bear in mind, you can alter these exercises. There's two things. One is the dose of air hunger. So you're always checking in. How much air hunger do you experience with this exercise? It's not about having a strong air hunger when you're doing breathe light. If you have a strong air hunger, you can't tolerate it because you have involuntary contractions of the diaphragm. Your heart rate is probably increasing. You're feeling stressed. So the air hunger should be within your comfort zone. It can be a little bit uncomfortable, but it shouldn't be stressful. Does that make sense? The other thing is pay attention to what your body is telling you. If you feel stressed, your hands go cold, your mouth goes dry, your heart rate increases. If you feel relaxed, your hands will get warmer. You have increased water saliva in your mouth, and your heart rate will slow down. We don't do coherent breathing so far. Buteyko is not part of coherent breathing. We don't count the breath. And the reason that we don't count the breath is as follows. Say, for example, you're a yoga instructor. Some of you here are yoga instructors. And we'll say that you're going into your studio, and we'll say that you're just working today with 3 students. So you have student A, you have student B, and you have student C. We'll say student A is a control pause of 10 seconds. We'll say that student B has a control pause of 20 seconds. And we'll say that student B has a control pause of 20 seconds and student C has a control pause of 35 seconds. So you're going in to give breathing instruction. And you're saying, okay, I'm going to have my students breathe in for 5 seconds and out for 5 seconds, because you know that this is a really nice breathing rate, coherent breath to help bring balance to the autonomic nervous system. So you're breathing in for 5 seconds, you're breathing out for 5 seconds. This is reducing the respiratory rate to 6 breaths per minute, which is really nice in terms of bringing balance to the relaxation and stress response. Okay, student A has a control pause of 10 seconds. They feel uncomfortable. You're instructing them to breathe in for 5 seconds. But because they're feeling uncomfortable, they'll fill their lungs. So they will breathe in for 5 and out for 5 seconds. Student B, they can tolerate air hunger. They feel fairly comfortable with their breathing. It's not too bad. So they will breathe the more normal volume for 5 seconds and out for 5. And student C, who is very light breathing, they can be breathing almost that their breath is imperceptible. In for 5 and out for 5. Now, all three students have followed your instruction. but the breath of the student A is entirely different to student B and student C. So for example, when we look at the respiratory rate, and this is what coherent breathing is looking at, only respiratory rate, it's not enough. We also have to consider how much air is that person drawing in one breath. And the volume of air that they draw in will depend on how comfortable they are in slowing down the respiratory rate. Student A, because their control pause is 10 seconds, their normal respiratory rate may be 20 breaths per minute. And all of a sudden, you're bringing them from 20 breaths per minute down to 6 breaths. The air hunger is too much. To compensate for that, they take a full breath. So their respiratory rate multiplied by tidal volume gives you minute volume. Student A, their breathing rate is 6 breaths per minute, but they're taking fuller breaths. We'll say that they're breathing 2 liters per breath. They are breathing 12 liters. That's hyperventilation. Student B is more comfortable with their breathing. Their control pause is 20 seconds. The respiratory rate is slowed down to 6 breaths per minute. And we say that the tidal volume is increased proportionately to 1 liter, and that gives you 6 liters, and this is normal. Student C has got very light breathing. They're just gently softening their breath. They're slowing it down to 6 breaths per minute, but we'll say that their tidal volume, they are hypoventilating, and they're reducing their minute volume down to 3 liters. So there's an entirely different breath here. That's why never just focus on the respiratory rate. And also when you hear the instruction, breathe in for 2 seconds and out for 7 seconds, or breathe, is it 4, 7, 8? Breathe in for 4, hold for 7, and out for 8. So 4, 7, 8. Okay, 4 and 7 is 11, and 8 is 19. 19 into 60 is 3 breaths per minute. Now, can you imagine somebody with anxiety trying to breathe three breaths per minute? So this is where giving an instruction, it's almost that you're just, I don't know, it's not good anyway. It's not going deep enough into breathing. It's only considering one aspect of it. Does that kind of make sense in terms of never just focus on the counting the respiratory rate, because it's not taking into consideration the depth that the person is breathing during that breath. Now, if you are teaching breathing and coherent breathing, and say, for example, you are a yoga instructor, you could give simple instruction. Breathe in and out, breathe in and out through your nose, but breathe silent. Because as long as they are breathing silently in and out through the nose, you're minimizing their risk of hyperventilating. And if you're a yoga student and you're doing yoga, instead of you taking the full deep breaths that may be prescribed, you can breathe nose, you can breathe light, you can breathe slow, you can breathe low. So you can change your breathing patterns to get the most out of it as well. Okay, so can we go back to exercise number 2B? So what I would like you to do is to put your finger underneath your nose as follows. The instruction is the same. All you're doing is just gently softening and slowing down the breath. So what I'm going to do is I'm going to open up the manual. So you start off with posture. Imagine there's a piece of string just gently pulling you up from the top of the back of your head towards the ceiling. Lengthen the distance between your sternum and your navel and widen the distance between your ribs. Awareness. Can you bring your attention out of your mind and onto your breath? Just bear in mind that some of the people that you work with, they're not going to have good concentration. People with sleep problems, they don't have good concentration. They feel tired. So you might have to show them their breathing. You might have to say, well, there's your breath coming in, and there's your breath leaving the body. So you're working with them to improve their awareness of the breath. Slowing down the breath, taking a shorter breath in and a really relaxed and slow, gentle breath out. So what I'm going to do is I'm going to simply now just read it off the script. So this will just make it a little bit easier for you. So just continue as you're doing, and I'm going to read it off this. So this is the exercise we're doing. It's exercise number 2B. It is a Buteyko exercise, traditional Buteyko exercise. So we start off with posture. Imagine there's a piece of string pulling you upwards from the top of the back of the head towards the ceiling. Lengthen the distance between your navel and sternum and widen the distance between your ribs. So gently straightening up, not forcing the body into position. Awareness. I'd like you to place your finger underneath your nose so that you can monitor the airflow from your nose. So this will give you feedback about how you are breathing. And bring your attention to the airflow on your finger. As you're breathing out, can you feel the warm air as it flows onto your finger? There's no need to place your attention on the movement of your chest and tummy. So don't worry about whether you are breathing high or low. Just focus and bring your attention to the airflow on your finger and really concentrate on the warm air as it leaves your nostrils and blows onto your finger. So this is awareness. You're getting people out of their head and onto their breathing. So now what I would like you to do is to slow down your breathing. As you feel the warm air on your finger, gently slow down your breathing. Take a soft breath in through your nose and allow a relaxed and gentle, prolonged breath out. I would like you to breathe so softly that you feel hardly any air blowing onto your finger. You can imagine that your finger is a feather and that your breathing is so soft that the feather doesn't flutter. Slow down the speed of the air leaving your nose. The objective is to slow down your breathing so that you feel hardly any air leaving your nose. There's no need to hold your breath or restrict your breathing. There's no need to deliberately interfere with your breathing muscles. Instead, just allow your breathing to soften by concentrating on the warm air as it flows onto your finger. The more warm air you feel, the harder you are breathing. Can you quieten and soften your breathing to the point where you feel hardly any air on your finger? The amount you are breathing during the exercise should be less now than what it was before you started. And you are doing the exercise correctly if you feel a tolerable need for air. So I need you to feel like you want to breathe in more air. So I need you to feel that you're not getting enough breath. The need for air should be tolerable, and it should be tolerable both during the inhalation and also during the exhalation. As you reduce the volume of air that you breathe, it is normal to feel a slight tension of the diaphragm. However, if you find that you are experiencing involuntary contractions of the diaphragm, then the air hunger is too much. If the air hunger is too much, take a rest for about 20 seconds and then go back to it. So the goal here is to maintain a tolerable air hunger for about 4 to 5 minutes. And we repeat these sentences. So I'm going back up to slow breathing. So what I would like you to do is really focusing and concentrating on the warm air on your finger. And as you feel the warm air on your finger, gently slow down your breathing. Take a soft breath in through your nose and allow a gentle and prolonged breath out. Breathe so softly that you feel hardly any air blowing onto your finger. Imagine that your finger is a feather and that your breathing is so soft that the feather doesn't even move. Slow down the speed of air, leaving your nose. The objective is to slow down your breathing so that you can feel hardly any air leaving your nose. So you know by the amount of warm air coming onto your finger. There's no need to hold your breath or try to restrict your breathing. There is no need to deliberately interfere with your breathing muscles. Instead, allow your breathing to soften by concentrating on the warm air as it flows onto your finger. The more warm air you feel, the harder you are breathing. Can you quieten and soften your breathing to the point where you feel hardly any air on your finger? The amount that you are breathing during the exercise should be less than what it was before you started. And you are doing the exercise correctly if you have a tolerable need for air. I need you to feel like you want to breathe in more air. The need for air should be tolerable both during the inhalation and exhalation. As you reduce the volume of air that you breathe, it is normal to feel a slight tension of your diaphragm breathing muscle. But if you find that you have involuntary contractions of the diaphragm, then the need for air is too much, and take a rest then and go back to it. Okay, so the goal is to achieve air hunger for about 4 or 5 minutes. So now what I would like you to take a rest. So if you can take a rest now. So the exercise that you're doing, you'll find the actual script for them. So this exercise is exercise number 2B. but every exercise has a script. All you have to do is read off the script. So when you're working with your clients, you simply read off it. So like it doesn't sound too bad. When I was putting this together, I was working with my own students and somebody was typing down what I was saying. So and then it was edited. So it has been edited a little bit, but other than that, the main part of it is there, you know. We use the word past. P is for posture. A is for awareness. S, short breath in or slow breathing. And T, we took a bit of liberty on that one, tolerable air hunger. So you can think of past. So all you're doing is just reading off the sentences, and then you don't need the manual. I'm going to go back to, this one is quite a strong one, variation C. Actually, I might do it now. You wouldn't do this tomorrow. Don't do this with the anxiety group because they'll feel too panicked. Or if you have a background of anxiety, it's too much. This is pretty strong. Now, I got the idea from a brown paper bag. Like, it's still based on Buteyko, but it's not necessarily a Buteyko exercise. It's a variation that I was using for kids, for teenagers, just to get them to feel air hunger. Or if I was working with some adults and if they didn't quite get it, I would have them do this exercise. I would like you to cup your hands as follows. So you're cupping your hands. So, and then I'm going to simply read it off the script. This is just to make you feel a bit more comfortable with it. Posture. I'd like you to sit up straight so as not to compress the diaphragm. Imagine there's a piece of string pulling you upwards from the top of the back of the head towards the ceiling. Lengthen the distance between your navel and sternum and widen the distance between your ribs. So I would like you to cup your hands against your face and have hardly any gaps between your fingers. So try and keep your fingers close together. This serves two purposes. Firstly, the hands provide good feedback of your breathing volume. So use your hands as a barometer of how much air you are breathing. The greater the amount of warm air you feel coming into your hands, the harder you are breathing. So feel the warm air as it enters your hands. Now, the other thing about cupping the hands is that it's naturally going to pool carbon dioxide inside your hands. And then as you breathe in, you're taking more carbon dioxide into your lungs, and this will increase carbon dioxide in your blood, and this will help to achieve a feeling of air hunger. Now, what I would like you to do is just breathe a little bit softer. So I'm going to go off script and go more gently. Use your hands as a barometer of the amount of air, the volume of air that you are breathing. Can you breathe 10% softer and see if that generates air hunger? So you don't necessarily have to cover your eyes. So you're basically just using your hands, you're cupping the face. And your objective is try breathing about just 10% less. Soften and slow down the speed of the air coming into your nose and allow a relaxed and a gentle breath out. So it's a soft breath in and it's a relaxed and slow and a gentle breath out. Does that feel air hunger? So do you feel air hunger there, by the way? Yeah. If you have air hunger, that's it. So using your hands can be a helpful way of getting the air hunger pretty quickly. Now, you could even just stay doing that just by saying two things: soft breath in and a relaxed and slow, gentle breath out. This exercise, though, you could go a little bit stronger. So what I'm going to do is I'm going to have you do it stronger just to test it, just to feel it. So now what I would like you to do is I would like you to take a short breath in through into your nose. With your hands cupping your face, only breathe in 1 centimeter or a half an inch of air into your nose. So you're breathing in for 1 centimeter. Then breathe out for 1 centimeter. So in other words, you're just breathing enough air into your nostrils and no more. You'll see this is tricky. So this is more for teenagers or people who don't get it, that you're getting them to really feel air hunger so that they can experience it, and then you can dial it down. But don't use this approach with people with anxiety and panic disorder. In other words, don't have them breathe in for 1 centimeter and out for 1 centimeter. Now, if you can practice it now, great. So I would like you to take a tiny breath into your nose and allow a tiny breath out through your nose. It's almost as if you were hardly breathing at all. Take a flicker of air into your nostrils and no more. As the breath in is tiny, the breath out is also tiny. Now, the goal is to create a feeling that you would like to take in more air. You're definitely going to feel it with this exercise. To create air hunger, your breathing now should be less than what it was before you started. I need you to feel a want for air, a feeling that you would like to take in a deeper breath. I would like you to feel slightly suffocated. If you're using that word, use it sparingly. People don't like it. The goal is not to pant. The goal is to reduce the tidal volume or the size of each breath so that less air enters the body. If your breathing muscles contract or if they start to feel tense, then the air hunger is too much. When this happens, take a rest for about 15 seconds and start again. It is normal at the beginning to take a rest a few times during the exercise, but with practice it becomes easier to sustain the air hunger for longer periods of time. Soften your breathing to the point of air hunger. Okay, so when you cup your hands, you can then choose which way you want to go with it. You could do it softly, almost when you cup your hands, you probably don't need to do a whole lot. So you could do it softly because as you cup your hands, you're pulling carbon dioxide, which in turn can create a feeling of air hunger, or you could breathe in for 1 centimeter and out for 1 centimeter. Did you have air hunger there? Yeah. So the main thing is that air hunger is uncomfortable, but the main thing is that people feel relatively okay with it. They feel, yes, I have air hunger, but you know what? It's a little bit uncomfortable, but it's not too bad. It's a similar sensation as if you're going for a fast walk. Now, there's also something, so when you see Paul taking a fine big yawn, you know it's working because when you have light breathing, it helps to activate the body's rest response. This is why we use it for people before sleep. So if you feel sleepy there, which some of you are, it's normal. When you do light breathing and slow breathing, it stimulates the vagus nerve, which in turn is activating the rest response. You feel sleepy. You might also notice that it's activating the digest response. How might you know if it's activating the digest response? When your body is ready for the digestion of food, what does it produce more of? Saliva. Saliva. Do some of you feel increased watery saliva in your mouth from doing the exercise? So you can see why we do it. When we're getting stressed. Now, tomorrow, we go through the anxiety. With some people, if they have anxiety or panic disorder, the air hunger triggers them into panic. Their mouth goes dry, the heart rate speeds up, and they get stressed. So not everybody has the same experience. But when you're doing this exercise, the objective is that you activate the rest and digest response. Okay. So we did 3 sessions there about breathing from a biochemical point of view. Now what I would like to do is a biomechanical point of view. There's a couple of ways of helping to engage the diaphragm breathing muscle. And we do want to breathe low. Now, one good way to help engage the diaphragm is simply go for a walk with your mouth closed. Because if you go for a walk with your mouth closed, you will naturally increase your respiratory rate and tidal volume. But you're increasing it relative to an increase of your metabolic needs. Does that make sense? There's a difference between somebody doing a breathing exercise and taking full deep breaths when they're stationary versus somebody who's doing physical exercise and allowing their breathing to increase relative to what they need. We don't want to hyperventilate. So if you go for a walk with your mouth closed, your nose is going to impose a resistance to your breathing. You're naturally going to be taking more air into your lungs and you'll have a better range of the diaphragm. So we want the diaphragm breathing muscle to move freely. Now, there's a couple of small little exercises that can be helpful if you feel that your diaphragm is not moving as free as it should be. 1, take a normal breath in through your nose and out through your nose and pinch your nose and hold your nose. And as you hold your breath, now gently try and breathe in and out as you hold your breath. So now gently try and breathe in and out as you hold your breath. And then relax and take a breath of air into your nose. So you're just doing this 3 times. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold your nose. And as you hold your breath, you're gently trying to take a breath of air in and out of your nose. So you should feel involuntary contractions of the diaphragm. And then let go, but breathe in through your nose. So it's almost that you're kind of just getting in there a little bit. So we wait about 10, 15 seconds and then we can do it again. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold your nose. And as you hold your nose, you're just gently trying to breathe in and out through your nose. So you're just gently breathing in and out through your nose. Okay. A second way to help engage the diaphragm is you could use a support, especially if you have somebody who's breathing a lot with the upper chest. So we have our own belt. It's called Buteyko belt. Now, the idea of the Buteyko belt is just to bring an awareness to breathing, but we also use it very much if somebody is breathing quite high with the upper chest. So you want to strap the belt just underneath the armpits, and you strap it there. Now, there's 2 straps here at which then you can adjust. So you want to get it to a point at which you can feel a resistance to the chest. The objective with this would be that the person who you are encouraging to breathe with good recruitment of the diaphragm, that they might put it on the morning time for 20 minutes or half an hour underneath their whatever jumper, and they just go about their daily routine. So as they go about their daily routine, the belt is pressing against their body to help encourage their breathing to go lower. So that's another way to help bring the breathing from upper chest. So you do want about 20% of movement driven by the upper chest, but 80% of breathing movement should be driven by the diaphragm. Now, the other option is, of course, you place the belt low. So you're then using it to bring awareness to the lower part of the body. Now, this size here is medium. So as you breathe in, that your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. So you're using the belt more so to really bring somebody's attention from the chest to the lower ribs. And you want to be encompassing the belt so that you're getting just at the base of the lower ribs, so you can kind of position it on the area of the diaphragm. Now, they can also do their physical movement with this on, because now they are breathing against resistance. So you're helping to improve the function, but also the strength of the diaphragm. So when you add an extra load onto something, you can help to improve the strength of it. So using a support can be quite helpful. Now, bear in mind, when you do your physical exercise with your mouth closed, you're naturally putting an extra load onto the diaphragm, breathing in and out through your nose. So during inspiration, there's greater work by your breathing muscles as air is drawn into your nose. But during expiration, it also changes the pressure when you breathe out through your nose, that you're having a slow and relaxed, gentle breath out. And the exhalation will tend to be lower and slower and longer. So bearing in mind that if you're doing physical exercise, yes, doing it with your mouth closed, breathing in and out through your nose is a help. Those belts are relatively inexpensive. They're not expensive. So I'm not sure how much they are, but you will see them anyway. They're on the training portal. But sometimes people don't have a great awareness of their breathing. So originally the Buteyko method, they used to wrap a sheet around their body, and they would tighten the sheet at a sufficient pressure to restrict breathing. So the idea was from babies who were swaddled years ago. So a baby was wrapped up quite tightly, and it may be that the baby was wrapped up quite tightly to gently restrict their breathing. In other words, to gently make sure that the baby wasn't hyperventilating, or providing a comfort for the baby. So that was where the idea had come from. But yeah. So there's 2 things kind of unique to Buteyko. One is wearing tape which has came from the Buteyko method, and the other is using a support to deliberately restrict your breathing. I've slept with the belt on as well, just to see in terms of the impact it would have on sleep. But yeah. So that's in terms of the biomechanics. So what I would like you to do now is I would like you to stand up. And I would like you to put your hands either side of your lower ribs. So to stand up and to have your hands either side of your lower ribs. And it's really about when you're breathing in, are you able to gently guide your ribs outwards? And as you breathe out, do your ribs gently move in? So you think about it this way. When we're taking a breath of air, the respiratory center is sending a signal to the diaphragm during rest. Your diaphragm breathing muscle is moving down by about 2 to 3 centimeters right now. As your diaphragm breathing muscle is moving downwards, your intercostal muscles are pulling out. This is increasing the volume of the thorax. It generates a negative pressure in the chest, so there's a vacuum which causes air to move into the lungs. So as you breathe in, are you able to push your ribs gently outwards? As you breathe out, do you feel your ribs gently moving inwards? As you breathe in, do you feel your ribs gently moving out? As you breathe out, do you feel your ribs gently moving in? Why is it very important that we have good function of the diaphragm? The reason being is because of the connection between the diaphragm and the upper airway dilator muscles during sleep. If you have good recruitment of the diaphragm, it increases lung volume and the throat is stiffer and less likely to collapse. Okay, so we'll take a break if I can bring you back to the computer. Now, no studies on it. I'll show you where I got that information. I was reading an article that was published in The Lancet in 2014. And this article here. And I just thought it was interesting because they were looking at adult obstructive sleep apnea, but looking at it from the point of view of the phenotypes, which we looked at earlier on: peak rate, loop gain, arousal threshold, upper muscle recruitment, and talking about different effects. So hopefully now I can find it. I might have to do a search. So I'll just put in lung volume into the search. Yeah. So lung volume might also be a causative factor. In animals and man, the cross-sectional area of the upper airway increases when lung volume increases. So if you're breathing with good recruitment of the diaphragm, you would naturally increase lung volume because you're using more of your lungs. And conversely, the airway is smaller. So your upper airway is smaller and collapses more easily when lung volume is small. So if you're breathing fast in upper chest, that's going to reduce lung volume and your throat is going to collapse more easy. This relation probably exists because the lower and the upper airways are mechanically linked. So you think about your lower airways, you're talking about your lungs, your diaphragm, etc., your chest cavity. And the upper airways, you're talking about your throat, the oropharynx, where the mouth is meeting the throat, and the nasopharynx, where your nose is meeting the throat. So your upper and lower airways are mechanically linked. So that would increase lung volume. The structures are pulled, resulting in stiffening and dilation of the pharyngeal airway. So your throat is stiffer and dilated when your lung volume is increased. And you increase your lung volume by good recruitment of the diaphragm. So good recruitment of the diaphragm as well, when you're breathing low, it also stabilizes the respiratory control system. Your breathing is naturally slower and it's helpful for better gas exchange taking place. So this is where I received that part from. So this paper here. Okay. So let's look at the client intake form now for sleep disorder breathing. And I also need to answer your question that if you were going to do a sleep study, how would you prepare for it from a breathing point of view? Okay. So we're going to go to the client intake form for sleep. This is what I give out to my own clients when they come in for sleep issues. And that's on page, sorry, 1 second there. Oh, I think I've got the old version opened because I only added those client intake forms. Yeah, it's not on this one. So it should be on the version that you have. So I need to find the new version. So just 1 second, sorry. I've got the old manual, I've since updated it. Buteyko. Yeah, so you should be looking for this one here. It's on page 279, and this will be the version you'll find uploaded onto the training portal. So hopefully it is. You have a client handout for insomnia, for snoring and sleep apnea. And it's really about if your breathing is dysfunctional or if your breathing is less than optimal during the day, well, your breathing during sleep is going to be less than optimal. So we're just going to scroll down. So your control pause is giving you feedback of how well you breathe. The objective is that we want to get the control pause a minimum of 20 seconds. And typically it will increase by about 2 to 3 seconds each week in the first few weeks. So if your control pause today is 10 seconds, it will take about three weeks plus to reach a control pause of about 20 seconds. And that's doing a fair amount of work. Breathing through your nose, breathing light, breathing slow, practicing the exercises. The importance of nose breathing is going to be relevant to whether you've got sleep issues, breathing issues, or anxiety. Nitric oxide is a very important gas that's released into the nasal airway, and we spoke about that yesterday. And then the daily practice program instruction. So there is one for asthma that is yesterday's, but for sleep, breathe only through your nose during rest, physical exercise, and sleep. The tongue should be resting up in the roof of the mouth, with 3/4 of your tongue resting on the roof of the mouth, with the tip of the tongue placed behind but not touching your top front teeth. Normally, I just get my clients to do tongue pops, which I think is taken anyway from myofunctional therapy. So I just have them do. So in order to make that sound, you have to press the tongue up against the roof of the mouth to create a vacuum. So your tongue should be resting in the roof of your mouth, 3/4 of your tongue up there. Nasal breathing doesn't automatically guarantee correct tongue resting posture. So if you are switching from mouth to nose breathing, it's also important to train the tongue. You should wake up with your tongue resting in the roof of the mouth in the morning. So when you wake up in the morning, you're looking to have that your mouth is moist and your tongue is resting in the roof of the mouth. We want to achieve a minimum control pause of 20 seconds plus. Practice breathe light for 5 minutes and repeat it 4 to 6 times daily. So this is the practice program for insomnia, for snoring, and for sleep apnea. So you want to get in 5-minute intervals throughout the day and get in about 10 minutes before sleep, because it's a really good time to do it before sleep to down regulate. If you think about, we need to activate the rest and digest response so that we can fall asleep more readily. But if we're overstimulated, we're not going to fall asleep so quickly. And it's very easy to be overstimulated with the amount of information that's thrown at us. Watching the news is not good in the evening time either. So if you want to watch the news, maybe watch it at about 1 o'clock in the day and just listen to it once or watch it once. Don't watch it in the evening, because it's not very positive, is number one. And you don't want to be watching the news and then go to sleep. So any sort of physical exercise is absolutely tremendous for improving sleep quality. 30 minutes to an hour per day at an intensity whereby you feel comfortably breathless. This way, it will improve your sleep quality because it's making you physically that little bit more tired, but it's also improving your breathing because you're breathing through the nose. You have to breathe with your mouth closed. So this way, you're adding an extra load onto the diaphragm, but also As you do physical exercise with your mouth closed, the pressure of carbon dioxide in the blood will have increased by about 3 millimeters of mercury. See, here's an interesting thing about doing physical exercise with your mouth closed. When you do physical exercise, you produce more carbon dioxide because carbon dioxide is a byproduct from your metabolism. If you're breathing through your nose during physical exercise, the extra carbon dioxide that you're producing, it can't leave the body quickly enough through your nose. So it's going to accumulate in your lungs. And as carbon dioxide accumulates in your lungs, it will increase in your blood, leaving the lungs. Now, what happens as carbon dioxide increases in the blood? It will improve blood flow to the brain. We would expect that when you do, the breathe light exercise that you did earlier on. So that breathe light exercise, we would expect CO2 in the blood to increase by about 3 millimeters of mercury. And every 1 millimeter increase of CO2 will improve blood flow to the brain by 3 to 4%. The breathe light exercise that you did earlier on, whereby you feel that you're not getting enough air, is increasing blood flow to the brain by about 10%. 10% increase in blood flow to the brain just by doing your physical exercise with your mouth closed. Now you have to think of the relevance of that for anxiety. So the breathe light exercise, increasing blood flow by 10%, going for your walk with your mouth closed, breathing in and out through your nose will also do the same. Doing your yoga, but provided that you're not breathing out through the mouth. The problem is if you breathe out through the mouth, you get rid of carbon dioxide too easily from the lungs. We shouldn't be getting rid of carbon dioxide too easily from the body. We want to expose ourselves to that higher CO2 to reduce the sensitivity to the gas carbon dioxide, because with reduced sensitivity to carbon dioxide, our breathing pattern then is naturally lighter and slower. So we as human beings, we can train ourselves to have less ventilation, but really what we're doing is we're looking to have more normal ventilation. So if you are doing any sort of routine that whereby you're breathing in through the nose and out through the mouth, why would you breathe out through the mouth? I really haven't got my head around that one. No animal does it. Newborn babies don't do it. It's not a natural, it's not something that nature does naturally. There's, again, what is the mouth doing when it comes to breathing? Zero. Your mouth is nothing. There's nothing in the mouth. That dogs do it to cool down, but that's because they use their tongue. They pass the air across their tongue to cool. So that's correct, Lucia. But dogs are one example. Penguins can have their mouth open, gannets, diving birds, but that's it. So if you were to look at, any sort of textbook at animals, of all of the species on Earth, about 3 of them resort to mouth breathing. Now, farm animals do also resort to mouth breathing if they are sick, but your nose is there for breathing. Always come back to the body. What happens if you're breathing out through your mouth? What does your nose do on the exhaled breath? It slows down the speed of the exhaled breath. If you breathe out with a slow, relaxed exhalation, what's your body telling your brain? Your body is telling the brain that you're safe. It's the speed of your exhalation that really matters. It's not the speed of your inhalation. If you want to induce relaxation, you're breathing in through the nose, but you're also having a relaxed, slow, gentle breath out through your nose. Your nose, by breathing out through your nose, it recovers heat and moisture from the exhaled breath. If you breathe out through the mouth, there's a 42% greater water loss breathing out through the mouth. So you're more likely to be dehydrated. So you think of your nose as expending an energy to warm and to moisten that air coming into the lungs. Or on a very hot day, your nose is expending an energy to cool and moisten that air coming into the body. But on the breath out, your nose is recovering that heat and moisture. So it's very important that, it's conservation. Try it with your phone. So again, you can use your phone as a kind of a means of seeing how much moisture is leaving the body if you breathe differently. You breathe out through your nose, you see a halo on the screen, and then turn around and breathe the same breath with your mouth. When your mouth breathe, it's almost that you cover the glass. So there's a 42% greater water loss breathing out through the mouth versus your nose. So it's really interesting. Like, see, the thing about breathing exercises, nobody's going to practice them indefinitely. I don't do breathing exercises formally, very seldom if I do it. But I did 30 minutes of my normal routine on the cross trainer this morning with my mouth closed, and that's what I try and get in every morning. I use my physical routine to use it as a breathing exercise, and as I do that, I also have my attention dispersed throughout my body, so I make it a meditation. We don't have time to do physical exercise, to do breathing exercises, to do meditation, to do this, do that. We're all time poor. So we need to be able to bring this into our normal everyday life. And then we'll continue with it, you know. So coming back to this. So to ensure that you're breathing through your nose, it's important to tape your mouth closed. Now, I do have a vested interest. MyoTape is my own product. Um, you can use any tape, really, you know. The only thing is I would never use any tape with children because there is a risk there. Some people who are anxious don't want to be covering their lips. You could use 3M micropore tape. We used it for many, many years. Now we use MyoTape because we have it. So, you know, if you are a little bit anxious about now, the other thing, sorry, I'm going to make a change. If you have moderate to severe sleep apnea, don't use a tape that covers the mouth. And the reason being is because it can make your sleep apnea worse. So I need to go to that. And then there's the breathing exercise instruction. So we went through the breathing exercise instruction already. And this is your daily practice program. So you give this handout. It's a separate handout in the training portal to your clients with sleep, your adults with sleep. So let's just briefly look at the presentation. If you're making a presentation, I'm flying to Geneva tomorrow. I've got a presentation on Friday with Ifuna. Some of you might know it. Sleep apnea. I will be giving the training. I fly to Geneva in the morning, but I give the training still to yourselves. I'll be doing it from a hotel. Now, I'm just looking for a presentation. 1 second. Because this is really important. This is the presentation. I just uploaded this version of the presentation to the training portal. This presentation was already up there, but I made a few changes to it. This consists of 89 slides, and it's really looking at the application, just looking at the theory, and this is the stuff that I spoke about, but it's a slide. Now, a couple of interesting points with this. Number one is if you have a stuffy nose, chronic rhinosinusitis, it reduces cognitive ability. So there's a significant decline in quality of life, and it is a chronic inflammatory disease. And patients with chronic rhinosinusitis, now this was looking with nasal polyps as well, poor sleep quality, impaired attention and perception, deterioration in cognitive function, difficulty in concentrating, and mood changes. It's really important that we get the mouth closed, breathing in and out through the nose. The results of this present study indicate that most patients, 90% of them, had symptoms of both nasal congestion and difficulty in concentrating. It's very, very interesting. Let's look at mouth puffing. So this was an interesting study. They actually used Somnifix and with mandibular advancement devices. So they had people who were wearing already a mandibular advancement device, but they had them tape up. And when they used tape, it increased the effectiveness of the mandibular advancement device. So in other words, if you do have a mandibular advancement splint yourself, or if you prescribe it, it's very important that you have your mouth closed while wearing the splint because it will improve the effectiveness. So they had them do 4 overnight sleep studies, a baseline night with no treatment, wearing the mandibular advancement device alone, or wearing the adhesive mouth tape alone, or doing a combination of the mandibular advancement device and adhesive mouth tape. Now, just bear in mind, the mandibular advancement device does not help people if they have lower arousal threshold and high loop gain. But if you bring in breathing re-education, it will. So 76% of people achieved an AHI of less than 10 events per hour when they wore mouth tape with the mandibular advancement device versus 43% in the mandibular advancement arm alone. So that's very interesting. That's a really good effect. So the conclusion was that adhesive mouthpiece and mandibular advancement is more effective than mandibular alone. Let's look at this though. So here's baseline, and here's mandibular advancement device, and here's mandibular advancement device with adhesive mouth tape. This guy here got worse. It went from 30 to 35 events per hour when they wore the tape. So did these two people. This person improved, but this person here got worse. This person improved. So quite a lot of people got improvements. Some people got worse. These individuals got worse because of mouth puffing. Their mouths were closed and they weren't able to breathe out through their mouth. So if you have people who are obese, don't tape across their lips. Or if they have moderate to severe sleep apnea, don't cover their lips altogether, because if they need to mouth puff and if they can't because their mouth is taped, it's going to increase, or it could increase, their sleep apnea. So that was one paper. Now you'll get these anyway. I spoke about a lot of this already. This here was also a paper looking at mouth puffing, and they were looking at one patient with OSA, but his sleep apnea worsened after being mouth taped during sleep. So then an ENT checkup, mouth puffing phenomenon was observed when the patient was asleep, indicating that the patient was trying to breathe through the mouth despite the oral device, so their mouth was taped, preventing them to do so. So they then conducted a study to investigate the role of mouth puffing. Now, mouth puffing is when you're breathing is that little bit harder and faster, and the air has to leave the body through any means possible. And if it can't leave the body through the nose, well, it's going to leave the body through the mouth. So they had 71 participants, aged between 35 and 60 years of age. 33% had severe sleep apnea, 22% had moderate, and 14.55 had mild. The patients with a higher BMI value had a higher proportion of mouth puffing. So if you're working with people and they're quite obese, don't tape their mouths because it can make them worse. And in this, now they do talk about breathing with an open mouth, of course. It is common with patients with OSA, and it is a problem because it narrows the airway. So that's why we do want to get the mouth closed with the tongue resting in the roof of the mouth. However, in this study investigating 71 people, the oxygen desaturation index of 30 people improved, so their sleep got better by mouth taping. However, 48% got worse. And the reason being is because they were mouth taped during sleep. And it was because the mouth taping was causing mouth puffing, the mouth taping was preventing them from mouth puffing, which is making their sleep apnea more severe. So that's why I think the myotape is safer in terms of just covering the lips. So you can make a call on it, but just bear that in mind. It's really important to get the mouth closed during sleep, absolutely vital. But if that person has a higher BMI, or if that person has moderate to severe sleep apnea, just bear in mind that the mouth taping could make their sleep apnea worse. Yeah. Now, it's not enough just to mouth tape at the same time. We also need to improve breathing patterns. And none of the studies looked at improving breathing patterns. There's no point in just throwing on Somnifix or something like that, and the person is going around with their mouth open all day long, breathing faster in upper chest with a control pause of 15 seconds. Like, all they're doing is putting a band-aid on, and they're doing nothing to address the underlying. This is where myofunctional therapy is a tremendous therapy as well for people with obstructive sleep apnea. Yeah. Okay. So are you comfortable enough? So that presentation is available to you. And if you're making presentations to healthcare providers, you can use this presentation. It's not as a PDF, it's there as a PowerPoint. You can add slides, you can take away slides. You know, there's quite a bit there. I actually went through it, even though I didn't use it. I just went through it just off the cuff. But yeah, same presentation. Okay, Barbara, you have a question.
Yes, hi.
Hey.
Uh, I'd like to ask for my mom a concrete example. She's 83, normal BMI, COPD, mostly asthma, and insomnia, have insomnia, and mouth puffing. I've learned about it because I slept
Yeah,
along with her because she broke her hip recently. So I would say mild apnea and mouth puffing. What would be the best thing for her? What would be the strategy for her for me to do?
I wouldn't use tape.
Okay.
Number one is because of her COPD, and I would be afraid that if we did restrict her breathing, that it would cause her blood oxygen saturation to drop too much. So absolutely, I wouldn't use taping. I think mild physical exercise during the day with her mouth closed would be tremendous, especially if she's doing something already. She can be doing any sort, if she was able to do a little bit of yoga, maybe a little bit of walking, um, any sort of physical exercise with the mouth closed. If she does wake up with insomnia, it would be helpful if she probably doesn't understand English, um, but we only have the guided audios in English using something that you could listen to help bring her back to sleep. So it's really about relaxation with light, slow breathing. She could do exercise number two, but if she was able to do it with relaxation and everything very, very gentle. Yeah, so that would be the approach. And I would be looking to get maybe 5 minutes, 5 times daily, just gently doing it, breathing in and out through the nose all the time. So in and out through the nose all the time, especially during physical exercise, and doing light, slow breathing. Even if you're just explaining, I want and I would like for your body to tell your brain that you are safe. Taking a soft breath in through the nose, a relaxed, slow, gentle breath out. The other thing, because of the COPD, the small breath holds could be quite useful. If there is airway obstruction that we can help to open, in other words, if it's reversible. So small breath holds. And she may not, because she's a little bit older, she may not understand the light breathing. Older people sometimes find it challenging. And because she's got COPD, it's likely that her control pulse is low, unless she's on oxygen, which is going to elevate her control pulse. It could be helpful to gently work with breathing low, but I wouldn't necessarily focus on it. I would focus on mouth closed day all the time, no taping at night. Exercise number 6, that would be her main exercise, the small breath holds, holding the breath for 3-5 seconds. Doing that, say, for 5 minutes, 3 times daily. And then exercise number 2A, doing that for 4 minutes, 3 times daily. Yeah.
Perfect. Thank you. Thank you so
Sure,
much.
sure, sure. Um, so running with the mouth shut stops irritation of the airway and therefore no mucus while running. You might notice, Douglas, it might increase a little bit when you start running. So initially, when you start to do your physical exercise with the mouth closed, you just might notice that your nose will run. But the more you do it, then your nose does dry up. But on a cold day, you might notice that your nose runs. So there are irritant receptors in the nose. So you might just have a little bit of mucus. It will depend on the person. It will depend on the person. So for some people, they may notice it. Marina, I'm currently having a rhinosinusitis and I'm practicing the nose unblocking, but the effect never lasts longer than a few minutes. This is normal. Because if you're having a cold or anything like that, when you do the nose unblocking exercise, it will help open up your nose. Then your nose gets stuffy. Keep gently working on your breathing, and you'll find that your nose will open more and more. Um, it could also be helpful to rinse out your nose with sea salt water. So, getting good quality sea salt just to clean the nose. Like normally, what I do is I just get a cup. I put in Himalayan sea salt or Celtic sea salt is quite a grey, unrefined sea salt, boiled water, allow the water to cool, and I simply just, I don't use a neti pot or anything. I just pour the solution into the palm of my hand. I hold one nostril. I snort the water in through the nasal airway, right down the back of the throat, and I hock it and spit it out. You want to get it right down, and then pour it into the other palm of the hand, snort it in. So you're cleaning out the entire nasal airway. I don't have a model of the nose. I always have them. I have to I'm in my offices here, but they've kind of put me in a different room because I make too much noise when I'm talking. So all my stuff is in the other room. But if I have an anatomical model of the nose, and you'll see that the nasal airway really goes back into the skull. In actual fact, if you do this with your tongue, put your tongue up into the roof of your mouth like this and drag your tongue along the roof of your mouth. So can you feel your hard palate? Can you feel your soft palate? That's the roof of your mouth. The roof of your mouth is the floor of your nose. So sitting above the roof of your mouth is your nasal airway. So when we think of the nasal airway as this is only about maybe 20%. 80% of your nasal airway is back. So yeah, always think of the roof of your mouth as the floor of your nose. So if you have a high palate like mine from years of mouth breathing as a kid, high, it's infringing the nasal airway. And because years of mouth breathing, a deviated septum, one nostril smaller than the other, so you can see the anatomical compromise there. I have a model of the nose, Angela. I think they're quite useful actually, the models, little plastic models there. Yeah, so you see Angela's version of it there, and we have them as well. So you can see the nasal airway there, and you can see the hard palate, and great demonstration there, Angela. So you have the hard palate, you have the soft palate, you have the turbinates, and you can see the extent. And also, the interesting thing about the nose is the communication from the nose into the brain via the olfactory nerve. You don't have that with the mouth. So you can imagine all of that communication by breathing in and out through your nose. And there were studies that they looked at memory and they looked at attention. And by breathing through your nose, it increased memory, it increased attention, it also increased visual spatial awareness. Partners select their mates based on the communication from the nose to the brain. So they did kind of interesting experiments. They got females to smell shirts worn by men. And the females were selecting, based on the scent, the females were selecting men from the opposite gene pool. So the researchers then thought that this was, you can imagine that we were in a small village 20,000 years ago. You didn't want mixing of the gene pool because then it would affect the health of the offspring. So it was very important that when a male and female, when they met, that they were actually dissimilar they weren't similar genes. And it's the communication from the nose to the brain that's helping to determine that. So yeah, anyway, that's just about the nose. I do have presentations, the 30 functions of the nose. I put them together last year, so you'll have that on the training portal too. So I think I've got through quite a few of the questions. I do need to go to, if you're going to, does a tonsillectomy affect nose snoring? I will look at tonsillectomy, Douglas. I will go through that, but I won't do it today because I'm going to do that with the kids session. How does Buteyko compare to 478 or 378? It's different. It's different. This is better, genuinely, because it's really direct. Or you could do 378 with light breathing with air hunger. The majority of older patients with asthma will probably have OSA. The best exercise for them, the ones we did, light breathing, slow breathing. With coherent breathing, you try to obtain 5 to 6 breaths per minute. I went through that. Box by 2 better. Again, you could do box breathing. I just feel the light breathing is so beneficial. And I just keeping it simple. Get that air hunger, but have it tolerable over the 3-4 minutes. Do you give your clients the scripts? Yes. Yeah. It's helpful for them because then they have something that they can go through. What does the belly do meanwhile? So if the ribs are moving, the belly shouldn't be rising and sinking. So basically, as the diaphragm is moving downwards, you will have some movement to your sides, a little movement to your front, and a little movement to the back. We don't call it belly breathing because what people can do is they can put one hand on their belly and they're pushing and pulling their belly irrespective of their breathing patterns. So that's why we want to get to have their hands on their sides. I'm currently having, oh yeah, I got that one. I'm scrolling down. Neti pots are useful, yes. Does Buteyko breathing help with ADHD? I will cover this, Judy, during the children's. Very often with ADHD, the problem is poor sleep quality. And children, if they have snoring and stopping of the breath during childhood, if it's untreated, it can affect brain development. So this increases then the risk of ADD, ADHD. So sleep and ADD, ADHD can be a link, and nose breathing and light breathing can help to improve their sleep quality to help the children be calmer. I found that switching to nasal breathing, initially it produced a headache. Yes, it can, Jojo. That's due to the vasodilation. So if you do physical exercise with your mouth closed, carbon dioxide is higher in the blood. This is increasing blood flow to the brain, and with the increased blood flow to the brain, it can bring on a headache. The breathe light exercise can do it also, but initially it'll only last for a few minutes. I'm a bit confused. The increased volume, diaphragm, breathing less. How do I spread the liters? See, there are different things, like when people focus on breathing low, they often take these full deep breaths. You don't have to. You can have the lightest of a breath while breathing low. If you put your hands either side of your lower ribs. Now, if you just practice it there with your hands either side of your lower ribs, can you take in the slightest, softest of a breath in and feel your ribs gently moving out? You can still have air hunger and breathe low at the same time. People often feel I have to be filling my lungs full of air to target the diaphragm. You don't. If you want to fill your lungs full of air, go for a run, because then your body needs more air naturally. If you're just sitting there or doing light movement, you don't need to be filling your lungs full of air because then you're hyperventilating. So the idea of taking these full big breaths, it should be matched with your metabolic needs. No animal is out in the field taking full big breaths because it believes that it's good. Animals are simply breathing in and out through the nose with a volume that matches their metabolic need. If the dog, well, I won't use a dog as an example, but if a horse goes for a run, the mouth is closed, and the breathing volume of the horse will increase relative to the metabolic needs of the horse. Whereas human beings, with their belief of different breathing exercises, they very often breathe more air because they believe that it's more oxygen going throughout the body, but they don't necessarily realize that breathing more air is getting rid of too much carbon dioxide, which is causing blood vessels to constrict, which is reducing oxygen delivery throughout the body, which can increase the chemosensitivity to carbon dioxide, which can cause the airways to narrow. So the full big breaths that are often taken, they're not always helpful. Can you say how you meditate when training in the morning? I do it very simply, Julie. I do my physical training and I don't have my attention stuck in my head. So I simply either have my attention on my breathing or I have my attention dispersed throughout the body. So I do my physical training with my attention dispersed throughout the body. So I train with every cell of my body. So I use then the physical training as a means of taking my attention out of the head. And I often do it throughout the day because I suppose when you're working with breathing, after a while it becomes kind of second nature that you don't necessarily have your attention stuck in your head so often. And the other thing is, when you improve your breathing patterns, you can help to bring a natural quietness to the mind that goes beyond just directed attention. It's not just that you're directing your attention. You can reduce brain cell excitability by improving blood flow and oxygen delivery to the brain. So the brain consumes about 20% of our oxygen. So a lot of oxygen, the brain needs a lot of oxygen, but we can influence that by changing our breathing. But it's not by taking the full big breaths. Carbon dioxide is a natural vasodilator and it will influence blood flow to the brain. And this is known for about 100 years. So there was a paper back in 1988, the brain by regulating breathing, the brain by controlling breathing regulates its own excitability. So if you control your breathing, how do you control it? It's not by taking big breaths. That's like sometimes people say, well, what about the Wim Hof method? And of course, I know some of you are dying to ask the question and things like that. The Wim Hof method is a stressor, but it's a major hyperventilation. So it is a hyperventilation, that's a stressor, and then it's a long breath hold, and it's a stressor. And that's why I was saying, anytime you're thinking about a breathing exercise, always ask, what is it doing from a biochemical point of view? What's it doing to carbon dioxide? What's it doing from a biomechanical point of view? What's it doing to the speed of your breathing? What's it doing to the blood oxygen saturation? And it's a pretty tough breathing exercise, the Wim Hof method. And there's a lot of people practicing it that shouldn't be practicing it. People with heart complaints. I would be afraid of my life for them to practice it in front of me because the impact it's causing, reducing blood flow to the heart, reducing oxygen delivery to the heart, and putting an extra stress in the heart. So we have to be careful with breathing. Breathing can be very powerful. It's like physical exercise. For some people, they should start off walking. Some people will jog. Some people will fast jog. Some people can run, and some people can sprint. The Wim Hof method is a sprint, but some people should be walking. Does that make sense? So in terms of breathing exercises, yeah. So it's not that one breathing exercise is better than another. Every breathing exercise has something to offer, but the main thing is that you provide a breathing exercise that suits the person that you're providing it to. You always have to ask, when you're giving a breathing exercise, what are we trying to achieve here? And the bigger picture is looking at the person's everyday breathing. It's not just how they are breathing on a mat or in a studio. That's only for a short period of time. More importantly is how are they breathing when they leave you? How are they bringing this into their everyday life? Because that's when breathing can be powerful, because you always have something at your disposal that you can tap into and you can use it then to regulate your states. It's a tremendous thing that you always have there, regardless. And I think the most important thing that breathing offers you is the ability to bring a quietness and a calmness to the mind. Tremendous. And it goes way beyond mindfulness. And if you are a mindfulness teacher, bring breathing with mindfulness. I worked with about 3,000 people from 2010, 11, and 12, and I called it Buteyko Mindfulness Method. Bring the two together. So that's what we'll be looking at. Now, hopefully my flights and everything are all perfect tomorrow. I will be talking to you from Geneva. I have to go now to Dublin tonight. And yeah, so we will see you at the same time, London time, but I'll be from a hotel room. So thanks very much, everybody. We see you tomorrow. Bye. Bye.